today is called the half and half training. So in order to get a special DEA license in order to prescribe Suboxone, every physician has to do a minimum of 8 hours of training. So today we're going to do 4 hours and 15 minutes of training. And then on your own, you're going to get a link and you're going to do 3 hours and 45 minutes of training online, answer a quiz, and then you will have finished the 8 hours of training that you need to do. You don't ever have to do the training again. Once you have the training, it's done. So even if 10 years from now you decide to use the medication Suboxone to treat people with opiate addiction, you will be able to as a result of this training. So basically the most important thing to remember, when you go to fill out the form on the computer, it'll ask you, what day did you do the 8-hour training? So you just have to remember 7/16/2020, because that's the day that you did the training. It'll also ask you for the city and state in which you did the training. So that would be Rootstown, Ohio. And that's the way that they'll be able to cross-reference you. So again, that's just some of the logistical stuff. So, all right, I'm seeing a little, meanwhile, I'm like also trying to check the chat. This is fun. Do today's questions during the live session count toward the quiz grade? No, they do not. They are just for me and Russell and Kay to prove that that most of you were sort of alive and on and trying to do the questions. So yes, that's the answer to that question. So, all right. So let me see if my slides actually work. Fun. Yes. All right. So there's the agenda. Introduction. My name is Chris Dallas Reyes. I'm a NEO-UCOM class of 1996. And from NEO-UCOM, I went straight to University Hospitals in Cleveland, my psychiatry residency and my addiction psychiatry fellowship, and I never left. So 2020 marks 24 years for me being at University Hospitals of Cleveland. So that's a pretty quick and dirty intro of myself. Again, I tend to have a lot of different interests, both inside and outside of medicine. So I hope that there's maybe some Harry Potter and Lego fans in the audience. And so from time to time, I might go and take a little diversion and have some fun. So those are things that are always top of brain for me. Those are things I like to do when I'm not doctoring. I also am a rabid Cleveland Browns fan. I know that's hard to believe, but that is me as well. What else can I tell you that's interesting? You'll find out more about me as we go along, I'm sure. So again, I know it's hard to sit through this. I know there's 150 of us here on the line or so. And so I look forward to getting into discussions with you via chat or just via discussion. We turn our mics, unmute ourselves and get to talk a little bit. That would be cool too. Again, if there is something that you don't understand, I'd rather answer the question, sooner rather than later, so you don't sit around and kind of wonder. So, so the first set of slides is really talking about what is Suboxone or what is buprenorphine naloxone, and how do we treat opiate use disorders with this medication. So the target audience, again, is doctors, residents, fellows, medical students, nurses, nurse practitioners, physicians, assistants. So the PCSS is the organization that's putting it on, and PCSS stands for the Physician, Physician Clinical Support System. So, all right, so let's start with talking about opioids. I wish I could get my chat box. Do we answer questions via the chat or the speaker? So you can, the quiz questions that I'm going to give you, we're going to do it in terms of like polling. So it's going to be kind of like Kahoot. Like we'll put the question up and then everybody online will be able to answer it. And then I'll be able to put up a slide that shows you what % of your classmates answered which question. So that's how we're going to do it.
Yeah, the polling's all through Zoom, so you don't need a phone or anything. It is all done through Zoom.
Nothing special. It's all through Zoom. So let's start by talking about the history of opioids. Again, this is not a new issue or problem. This has been around as long as there have been opium poppies growing. So that's been a very, very long time. So probably predated humans to some extent. So opioids have been used throughout the world for thousands of years. In the 1800s, morphine and heroin, believe it or not, were marketed commercially as medications for pain, anxiety, respiratory problems. So, and then what happened is the hypodermic needle or syringe got invented, which made for even faster delivery to the brain. And what you see here is sort of the pod. And so this is an opium poppy, and then this is the pod that forms. And then they extract that like milky white substance from it. And then that's where they get the morphine out of it. And then what they do is they just stick two acetyl groups onto the morphine, and then you get diacetyl morphine, which is actually heroin. So heroin is nothing more than a morphine molecule with two acetyl groups on it. So that's what that is. Why are my slides going forward? Okay, so these are some of the pivotal milestones in the treatment of addiction. So it's a relatively new thing. So back in 1970, methadone is a medicine that actually got FDA approved to detox people from opiates, and then 3 years later, methadone was then further approved for maintenance treatment of people with opiate addiction. And in 1974, they established a federal system of what is called OTPs, which you may better know as methadone clinics. So they established these centers all over the country, and these centers were able to dispense methadone for the maintenance treatment of opiate addiction. Then 10 years later, naltrexone got approved by the Food and Drug Administration, and that was an antagonist that's used to treat addiction. And then finally, 16 years later, so this is now back in the year 2000, Treatment Act of 2000, which we for short call DATA 2000, allows qualified physicians to offer office-based opioid treatment, which is basically treating people with Suboxone. 2 years after that is when buprenorphine got approved by the FDA. And then 8 years later, extended release injectable naltrexone, which is a monthly medication, got approved by the FDA. And then just a couple of years ago, CARA came along, and CARA is the Comprehensive Addiction and Recovery Act. And this is what expanded treatment. So not only doctors and residents and fellows, but then this is when nurse practitioners and PAs sort of got into the game, and they also became eligible to prescribe buprenorphine. So there are particular requirements, both of the practitioner as well as of the medication. And so we'll talk about the practitioner first, and then we'll talk about the medication. So in order for any of you to be able to use this 8-hour training, you have to have several things. So you first of all have to be a licensed provider. So you have to have graduated from your medical school and have an independent license and have an independent DEA number. So we got to get that hurdle done first. You have to either do a year-long training in addiction as part of an addiction fellowship, or you can complete this handy-dandy 8-hour course, which is what we're trying to get you through. You have to then register online with SAMHSA, which is the Substance Abuse and Mental Health Services Administration of the United States, as well as the DEA. And then you have to basically check a box in which you swear that you have the capacity to refer people for further counseling if they need it. And then you have to adhere to particular patient limits. So one of the most interesting things, or a unique aspect of this treatment, is it's the only drug that I know of where the federal government tells you how many people you can treat with the drug for as long as you have your license. And so in the first year that you have your special license, which is called your X waiver, in the first year of your X, you are allowed to treat 30 people. And then in the second year of your X, you can treat 100 people. And then after your second year, then you are allowed to, under special circumstances, treat 275 people. So if you think about all the medications that you're going to be able to prescribe in 24 months from now. So in just a very short time, you will be able to pretty much prescribe any drug that you want to. If you want to prescribe this drug, you first have to finish the 8-hour course, and then secondly, you're only allowed to treat a limited number of people once you have this number. So those are just some things you need to know sort of off the bat. So again, as I referred to, 1,000 permitted particular doctors, and now NPs and PAs, as long as you meet certain qualifications, you can treat opioid addiction with particular medicines. So the medicines have to be in Schedule 3, 4, and 5 I think it's the DEA scheduling. And so the DEA schedules basically let you know how addictive a medication is. And so anything that is a scheduled drug is basically deemed potentially addictive by the government. And there's 5 different schedules. So there's Schedule 1 contains things like marijuana, heroin. 2 contains things like cocaine, Vicodin, Percocet. Schedule 3 is where buprenorphine lies. So that's where Suboxone is. Schedule 4 is where something like Valium lies. And then Schedule 5, there's other milder drugs. And so Schedule 1 is sort of deemed the most dangerous. Schedule 5, the least dangerous controlled substance. So that's what those schedules are. So basically the law says that you can only use Schedule 3, 4, and 5 drugs to treat people with opiate addiction in a treatment setting other than a methadone clinic. Okay, so it just, and again, if some of this is like, I hope I can explain it when we get to Q&A. So basically the DEA is responsible for enforcing Data 2000, and basically what they want to do is make sure that you're not going over the patient limits, and they will sometimes every so often come by and inspect you and make sure that you're doing everything correctly. If you are going to treat buprenorphine patients, you're supposed to keep a log of those patients, and you're supposed to have the information easily accessible so that you have a non-onerous inspection by the DEA. Doesn't that sound like fun? So in the 18 years that I've been doing Suboxone, I've only been visited by 2 DEA agents at the same time. So they always come in pairs. They were not wearing like, black trench coats or anything like that. They just sort of looked like normal people, but they did have the official looking badges. And, they came down and talked to me and looked at a couple things in my office, and then they sent me a letter afterwards. And so it wasn't that bad, but I'll tell you what, I was nervous. I can actually still remember that day. So I've got a little PTSD from the day I, heard that knock on the door, like, Dr. Chris, we're here to inspect your office for Suboxone. So it's fun stuff. So So what are the treatment goals when you're treating somebody with opiate use disorder? There certainly are a range of treatment goals. And so on the one hand, the left hand of side of this slide, you want to basically minimize the harms that are taking place for a person that's using. So if you can prevent them from getting HIV, prevent them from spreading hepatitis C, for example, I think those are good, pretty decent goals. If you can prevent them from dying, always a decent goal for a physician, all the way up to and including, can you get somebody into sustained recovery and abstaining from all substances of abuse, so not just the opiates. So again, you've got a very wide range of treatment goals. And so according to the Federation of State Medical Boards, about 7 or 8 years ago, they put out a menu of various treatment options that you can use to treat somebody with opiate addiction, and that's what's listed here. And so the first 3 bullet points are medications. We're going to spend the vast majority of our time today talking about buprenorphine, which is a partial agonist at the mu receptor. We're going to spend a few minutes talking about methadone, which is an agonist or a full agonist at the mu receptor. And then we'll spend some time as well talking about naltrexone and naloxone, which are antagonists at the mu receptor. So the other thing I find fascinating about the disease of opiate addiction, you can use medications that have 3 different mechanisms of action, all to treat the same disease. I'm like, oh, that's pretty weird, but yes, that's actually true. You can do simple detoxification without any other treatment. Personally, I wouldn't recommend it. I think that's a really crappy treatment option. So if it was me, I would be crossing that off the list. You can do counseling and peer support without MAT. Yeah, you can do that, but it's the without MAT that makes me kind of nervous because the person is at high likelihood for relapse. And then you can also refer that person to short-term or long-term residential treatment. So what happens in real life is usually that the person is doing a combination of things on this list, one thing on the list. So again, certainly lots of treatment options for this disease. So, all right, keep switching off of there. All right, so why do we bother talking about buprenorphine? Why does this work? Basically, buprenorphine promotes treatment retention, and we know that people that stay in treatment are more likely over time to abstain from other opioids. And so what you can see is that if you called the survival curve. And so you can see it along the bottom over a year's worth of treatment. If the person is on buprenorphine, you can see that about 60% of them remain in treatment over the first year. And of those people that remain in treatment, you've got about, what's the number there? You got about 80% of them that have been opioid negative for the last month. So not everybody stays like sober, but you got 4 out of 5 people staying sober, which is actually pretty good odds. So that's one of the reasons we know that this is useful, because of the treatment retention data and the opioid negative urine data. So again, it also is helpful because it prevents people from dying. And so as a physician, I'm always interested in what can I do to help keep people alive? First, you got to keep them alive before you can get them well. So my goal in life is to keep people alive and well. So, but first you got to keep them alive. So one of the benefits of medication-assisted treatment is that you have decreased mortality. So this is a grid showing you death rates in the general population. And so that's the green bar. And so they basically set that at 1. And then they say, well, let's look at people that have opiate use disorders and let's not give them any treatment. And so if you do that, their death rate is 6 times as high. You're 600% more likely to die if you have an opiate use disorder and you're not treated. And then if you do put somebody on medication-assisted treatment, which is one of the 3 medications that I referred to earlier, if you have somebody on medication-assisted treatment, you can see that their mortality drops to twice that of the general population instead of 6 times that of the general population. So I don't know about you, but as a doctor, that's pretty good odds. So it's like, that's pretty useful. So if I can get this to keep people alive, then yes, absolutely, we should do it. So you can look at it as life-saving treatment. So just to summarize on that little section, there's been a number of laws that have been passed to try to improve access to treatment for people with opiate addiction. And Data 2000 is unique because it allows for the treatment of an opioid use disorder to happen outside of a methadone clinic with very particular medications. And we know that these medications are useful because they decrease the number of fatal overdoses, and they also increase patients' retention in treatment and improved social functioning. So I'm seeing some things in the chat, which I'm gonna peek into. All right, I'm being asked the breakdowns for each medication and their ability to reduce the mortality. That's a fantastic question. I think that methadone has the highest level of success, followed by buprenorphine, and then followed by naltrexone. So it's in that order. So methadone most beneficial in terms of decreased mortality, then buprenorphine is a close second, and then naltrexone falls off a little bit, and I can explain why when we get there. So thank you very much. That's an excellent question. So, all right, back to the slides. All right. So there's some reference slides. Get those there. All right, the fun part, the pharmacology. So, so we're going to talk about methadone first. This is a full agonist, so it's this line right here in green. And then we're gonna talk, I think, about naloxone and naltrexone, which is the antagonist. That's the red line. And then finally, we'll talk about buprenorphine, which is the partial agonist, or the blue line. So first, let's talk about methadone. Methadone is a full agonist at the mu opiate receptor. It's very long acting. It has a long half-life of between 15 and 60 hours. So that's the reason that when you do a dosage increase on methadone, you try to do it every 5 to 7 days, because you have to wait for steady state to happen. And it has a very weak affinity for the mu receptor, which means that other drugs, such as buprenorphine, and drugs such as naloxone, can bump the methadone off of the mu receptor, and that can cause something that's called precipitated withdrawal. So we can talk about how that all happens. And methadone, because it is a full receptor, it requires some monitoring through a methadone clinic. So I'm not sure how many of you have had experience with patients that have been at methadone clinics, but basically if you're at a methadone clinic, you have to go to the clinic single day, 6 days a week. Drink your medicine, because it comes in a liquid. Drink your medicine in front of the nurse, who's usually behind the bulletproof glass. And you drink your medicine in front of her, and then you step out of line. And then there's like 50 people behind you in line. And so everybody has to line up and drink their methadone in front of the nurse. And you have 6 days a week. And then on the 7th day of the week, to give everybody a break, what they'll do is they'll give you a little tiny bottle of the methadone, and then you save that for like Sunday morning, and then Monday morning you start all over again and you go to the clinic. So as you can already understand, one of the problems with methadone treatment is, number one, there's not enough clinics, and they tend to be in very large cities. And number two, you're kind of chained to the clinic because you have to go there 6 days a week. Earn your way to something called take homes, where you can earn enough take homes that you only have to show up to the clinic on Monday, drink your stuff in front of the nurse, and then they'll give you 6 bottles for like the rest of the week. So you can basically earn doing it like that. That's actually in the state of Ohio, because state law differs from state to state. So there's a couple states in the union where you can earn 29 take homes in a month. But in Ohio, you can never earn more than 6 take homes. So they're super strict in Ohio. So even if you've been on methadone literally for 25 years, it doesn't matter. It's 25 years of coming to the clinic at least a week and then taking home your 6 take homes. So that's the way it goes. And it's because it's a fairly sort of dangerous drug. So yes, you can actually overdose and die if you're going to take too much methadone at once. So it's basically in the same class as like heroin or morphine. And it also can cause QT prolongation on your EKG. So that can cause a lot of heart arrhythmias. And of course, like every opiate, it can stop your breathing. And that's what kills you when you overdose on it. Just like it's the same thing that kills you when you overdose on morphine or heroin. So that's methadone. I guess we're going to do naloxone. So the major features then of buprenorphine, which is the drug in question that we're talking about today, is that unlike methadone, which is a full agonist, buprenorphine is a partial agonist at the mu receptor. What does that mean? Well, from a pharmacology standpoint, you know that a partial agonist, it doesn't turn the signal on the receptor all the way up to 10. So a partial agonist, even if you're taking it exactly the way as you're supposed to, the highest that you can turn the knob on that receptor is like a 5, for example. So we can only partially turn on the receptor. That makes it very valuable because it's extraordinarily difficult to overdose on buprenorphine alone. So there's very little respiratory suppression, and if you take it as prescribed, it's nearly impossible to kill yourself with buprenorphine alone, because what happens, as you can see on this grid, is that you get this plateau effect, so that no matter how much buprenorphine you have in your system, it's not going to turn the opiate receptor on anymore, and so you're not going to get the full respiratory suppression. So that's one of the things that adds to its extreme safety profile. It's actually one of the safest drugs out there, and when I teach this class, and I've heard a lot of other teachers teach this class, they often will say, hey, look, this medicine is safer than Coumadin, and it's safer than insulin, which are things that doctors prescribe like every single day of their lives, especially primary care doctors. I mean, I'm not out here prescribing insulin and Coumadin, but as a psychiatrist, but a lot of my colleagues are. So anyway, so buprenorphine is a very long-acting drug. It has a half-life of 24 to 36 hours, so that's another good thing. And then, unlike methadone, which you saw on the previous slide, it has a very high affinity for the mu opiate receptor. And the other thing that makes it super useful is that it has a slow dissociation from the mu receptor, which means it's very sticky and it stays on the receptor for a very long time. So the fact that it has a high affinity makes it useful in blocking other opioids. So imagine this is like your opiate receptor. Here comes the buprenorphine. It's sitting on top of the opiate receptor. And so if heroin comes along or if methadone comes along, it's got such a high affinity for the receptor that you can't knock the buprenorphine off the receptor, which means that if the patient is taking their buprenorphine and they happen to relapse on heroin, they're not going to get high from the heroin. They're not going to feel any of the reinforcing That's how it works. So, but the opposite is if the person's on heroin and then you introduce buprenorphine into the system, it's the buprenorphine that knocks the heroin off the receptor, and that's what throws the person into a precipitated withdrawal. So those are, again, some of the things you need to know about this medication. So, and then finally, the major features of naltrexone, which is the red line down at the bottom, which is an antagonist. Naltrexone is a full antagonist at the mu receptor, and it also is a long-acting drug. The pill form has a relatively short half-life of 4 hours, but if you do the monthly injection, that's got a half-life of 5 to 10 days. So that's a very, very long time. Once again, like buprenorphine, it has a high affinity for the mu receptor. It can block other opioids and it can displace other opioids. So the question you might be wondering is, in a boxing match, which drug would win? Would the naltrexone bump the buprenorphine off the receptor, or would the buprenorphine bump the naltrexone off the receptor? And the answer is the naltrexone will bump everything off the receptor, including buprenorphine. So that's the deal with that. So there's a couple of ways you can take this medicine. It's a tablet around since 1984, and then there's an injection, which you may be familiar with, called Vivitrol, which has been around for 10 years, and that's a once-a-month medication, and it has to be given in the gluteus. So yeah, you have to you have to get that shot in your butt. So because the needle is about like yay big, and so you can't do it in your arm. That would hurt. Hurts as it is. All right, so let's go back to buprenorphine for a quick second. Buprenorphine is an analog of a pain medicine called Thebane. So a lot of people don't realize that buprenorphine had a life before it was Suboxone. So back in the day, buprenorphine was just a pain medicine. That's all it was. So it's extraordinarily useful at treating pain, and it only got approved in 2002 as a Schedule III medication for the treatment of opiate use disorder. So they, obviously, they knew that they were going to release buprenorphine, and they knew that Data 2000 said you had to use a Schedule 3, 4, or 5 drug. So they scheduled it in Schedule 3 on purpose. I mean, they did that on purpose. And this drug is metabolized in the liver. It's mostly metabolized by your P450 3A4. So the important part to remember is the 3A4 part of it, because that will come up over and over again. And then it does have an active metabolite, less active than the main drug, but the less active metabolite is called norbuprenorphine. So sometimes you'll hear people call it Norbup for short. And in fact, most people call bup for short, because you just get sick of saying buprenorphine. So the bup is excreted into the biliary tract, but there are some parts of it that get into the urine, and then you can detect the buprenorphine in the urine. One of the things that you also have to know about buprenorphine, which makes it unique, is that it is a sublingual drug. You have to melt it under your tongue. If you swallow the buprenorphine pill, you're wasting your time. So what happens is that if you swallow the pill, you're only going to get 5% bioavailability. So it's like you're not taking it at all. And so it's not going to work very well for you. However, if you take it under the tongue like you're supposed to, your bioavailability is up around 30%, which still isn't great, but at least it's better than, less than 5%. So in order for this drug to work, you have to take it under your tongue. So when you're troubleshooting with a patient and the patient's like, man, it doesn't seem like this drug is working, the first question you have to ask them is, tell me exactly how you're taking it. And if they just say, yes, I, slug it down with some coffee or some orange juice, then you'll immediately know where the problem is, because they're not melting it under their tongue. So you just have to make sure that it's being given sublingually under the tongue. All right, so we're talking about how does this actually work. Buprenorphine basically works because it has a super strong affinity to the receptor, and it has a super slow dissociation from the receptor. So that's two different pharmacological aspects. So the receptor binding strength is not the same as its ability to turn on the receptor, right? So number one, buprenorphine is a partial agonist, which means it only turns the receptor on to, say, 5 out of 10. But the affinity is the fact that how strongly it sticks to the receptor, which is different than how much it turns on the receptor. So the strong affinity is what allows it to knock off heroin, methadone, or any other full agonist off of the receptor. And then the dissociation is how fast does it uncouple from the receptor, and uncouples very, very slowly, which is, again, why it works. So not only can it knock off other drugs off the receptor, it can also prevent those getting to the receptor because its dissociation is so slow. So you might be wondering, can it block all the effects of all opiates? It's unlikely that it's going to block absolutely everything, but certainly it works well enough to get people, to give people their lives back. Let me just put it that way. So that's sort of the bottom line, right? We can argue about the fine tuning of the pharmacology and stuff, but the bottom line is, yes, it works like a charm. Actually, it's, I've been doing psychiatry for what, close to 24 years, and Suboxone is up there in like my top 5 favorite drugs because, damn, it actually works. There's a lot of stuff I do in psychiatry that doesn't work at all. It's like mostly the placebo effect and the power of suggestion. But buprenorphine is the real deal. So I love it. All right, so here's again, just because you all are scientists and you like these science slides and they like to make data slides, that's why I got to show you these things. Oh yes, the other thing I have to tell you is that the the 249 slides or whatever that I have to show you in 4 hours, it is a national slide deck, and everybody that teaches this class has to use the exact same slides. You're not allowed to deviate from the slides, but I am allowed to tell you my own little side story, but can't deviate from the slide. So this basically, the way to read this is that you're looking at the buprenorphine dose at increasing levels. So you've got 1 milligram, 4 milligrams, 8 milligrams, and 16 milligrams. And then on this side of the chart, you've got the percent of patients that can give you 13 consecutive opiate-free urines. So that's a lot, right? That's like 12, that's 3 months of, pretty much the person hasn't been using for 3 months. So, take a look. And so what you can see, without even looking at any of the numbers, you can see a dose response effect. The higher the dose, the better the response. But when you look at it, it's interesting that even at the highest dose, which is 16 milligrams, you can get 25% of your patients to give you 3 months of clean urines. So you might think, damn, that's not that good. But, if you give them nothing, which is basically like giving them 1 milligram, then you can get 5% or 1 out of 20 of your patients to stay sober for 13 consecutive weeks. So you kind of have to look at it just sort of as a relative thing. So when I look at 25% versus 5%, what I say to myself is, hey, if I put buprenorphine, I'm 500% more likely to be successful at keeping them sober than if I give them like nothing, because the 1 milligram was basically like their placebo condition. And so on and so forth. But I hope it tells you at least that, this is a very difficult disease to treat, and medicine is certainly not a magic bullet, although every patient with opiate addiction is always going to be coming to you looking for the magic bullet, and you just got to tell them it doesn't exist, honey. There is no magic bullet. I mean, this will help, certainly, and it's fantastic, but you have to do other parts of the footwork, and we'll talk about what that is as well. So the other thing that it does is it decreases craving. And so again, you can see the 1 milligram, which is basically like placebo in this little puke green color, versus the 4 milligram, the 8 milligram, and the 16 milligram doses. And you can look at the craving scores that basically drop drastically when you have somebody with this medicine. And if you treat somebody with basically placebo, their craving scores go down a little bit, but they basically stay high. So less craving and fewer positive drug screens. So we got that already. This is probably one of the most relevant slides. So we're looking at 14 weeks, and this is what's called a survival curve. So we're asking the question, how many people stayed in treatment? And so what they did was they took all the patients, and at the beginning of the study, 100 of them were retained in treatment because it was like week 0. And then what they basically did is say, all right, we're going to treat everybody for a month, But then at 4 weeks, we're going to take half the group off buprenorphine and we're going to let half the group stay on it. So they let half the group maintain the medication, and they took the other half off of it. And it's pretty dramatic that if you take somebody off of it, sometime in that first 14 weeks, you will lose 80%. They'll just drop out of treatment. They won't be able to stay sober and clean. But if you keep people on the medicine, you'll be able to retain somewhere in the neighborhood of 65, 70% of patients, which is pretty darn good. So the retention and, in treatment is also much better, much, much better. So what are some of the drawbacks of buprenorphine? Like every drug obviously has side effects. So some of the most common adverse effects that you'll get from the buprenorphine are headache. Again, and most of those are symptomatic treatment. They can take aspirin, Advil, Tylenol, as long as they're allowed to take those medicines. You can use that to treat the headaches. Some people will get from the medicine. So when you melt it under your tongue, a lot of times you have a lot of extra spit in there. And so sometimes the dosage is a little bit too strong. So you would tell the patient to spit out some of the saliva if they're getting too much of the medication, although most people need every single bit of the medicine. So, but you do that. And then I would say that 95% of my patients on buprenorphine have constipation. And so that's something that I'm managing all the time. You need lots of fluids, you need high fiber or Metamucil. You can use stool softeners like Colace. You can use laxatives like Miralax. I tend to use Miralax a lot. You can use something called naloxegol. I've actually never used that, but I suppose you could use that as well. And then every single opiate in the class, even the partial opiates, can cause dry mouth. And so again, you got to stay well hydrated and you got to brush your teeth. So heroin addicts and other types of addicts are not very fond of brushing their teeth. And so a lot of my patients that are in their mid 30s to early 40s, like, have already had all their teeth pulled and they have dentures because their teeth are awful. So yeah, that's just a common side effect. So I'm seeing a bunch of questions come up, so I'm going to switch to my chat before going on here. How do I do it? Okay, here we go. Gotta get better at this. Okay, so let me, yes, PowerPoint will be posted in AIMS. Okay, we talked about the breakdowns. Asking to make sure after completion of getting your MD and getting your independent license and getting your DEA license, you can then prescribe Suboxone to 30 patients at first, and then 100, and then 275. That is absolutely correct. So got to get the MD first, got to be independently licensed in one of the 50 states, and then you have to have your independent DEA license. Now that you're about to complete this 8-hour training, you can immediately apply for what's called an X number, and then you can start prescribing Suboxone. But let me tell you guys too, because one of the things that they never explain to you in any of these slides is they don't explain to you what your X number actually is. So this is a good time for me to take a little break here. So your X number, so for example, your DEA number, so your DEA number anywhere across the country is always 2 letters followed by 7 numbers, okay? So your DEA number could be AB 1, 2, 3, 4, 5, 6, 7. So somebody in the world has that very handy dandy DEA number of AB 1, 2, 3, 4, 5, 6, 7. So what is an X number? You take off the first initial, so you take off the A, and so your X number is XB 1, 2, 3, 4, 5, 6, 7. So when you write a prescription for Suboxone with the intention of treating somebody with opiate addiction, you have to write both DEA numbers on the prescription. So you have to write AB 1, 2, 3, 4, 5, 6, 7, take off the A, and then you have to write XB 1, 2, 3, 4, 5, 6, 7. That's your way of letting the feds know and letting the pharmacist know that, hey, I've done the 8-hour training and I'm intending to give Suboxone to this person for opiate addiction. And so I'm writing my X number on the prescription. Again, it's the only medicine I know of where you have to have a special number that's different than any other number you have in medicine. I mean, it's crazy making. And a lot of that has to do with politics and stigma, which is also something that gets me hot under the collar, and we'll talk about that. But that's the deal. So if you ever wondered what your X number is, it's just whatever your DEA number is, take off the first letter, replace it with an X. That's your X number. way more than you wanted to know, TMI. All right. Would a person have to come to the clinic for buprenorphine and naltrexone like they do for methadone? Fantastic question. The answer is no, which is what makes it so convenient. So the reason that buprenorphine is sometimes called OBOT or OBOT is because it's office-based opioid treatment, which means you can go to the privacy of your own doctor and nobody needs to know your business, right? Because if you show up in downtown Cleveland at East 11th and Carnegie, everybody knows that you're there to go get methadone, which means that everybody knows that everybody standing in that line has a problem with heroin or other opiates. So it's very stigmatizing if you show up at the methadone clinic. But with buprenorphine, you can go to the privacy of your doctor's office. And when you're doing really, really well on buprenorphine, you can show up at your doctor's office 4 times a year. So I've got patients that I've been treating for 10 years with buprenorphine. They're doing fantastic. They haven't used heroin in 10 years. I see them 4 times a year. I give them a 1-month prescription with 2 refills, which covers them for 90 days. And so I see them every 90 days. It's beautiful. So they're not chained to your office. They just have to come see you 4 times a year. Now, obviously, at the beginning of treatment, you're going to probably want to see them like once a month. But when they're doing great, you see them once every 3 months. And the same is true for naltrexone. Naltrexone is not even a controlled substance. So it's not on one of the DEA schedules. So you can actually do naltrexone. You could literally do like a month and 11 refills if you wanted to. Not that you would ever want to, but with naltrexone, you could literally see somebody once a year. But I wouldn't recommend that because so much happens with the disease of addiction that you probably at least want to lay eyes on somebody like at least every 90 days. So that's a fantastic question, and thank you for asking that. And then another question is the percentages that I showed you, do the percentages add to give us roughly 65 to 70% are good with their treatment for several days or months? Or are they the same patients and I change their dose up to make them more likely to stay off drugs and on the medication? I think the answer, without looking at the actual article, it's hard for me to say exactly. But what I would say is that the people that were in the 1 milligram group, 4 milligram group versus the 8 milligram group versus the 16 milligram group, they were all different people. So, and what they were trying to prove was, does a different dose make a difference? So they probably matched all the patients in each group on like age and gender and socioeconomic status and all that kind of stuff. And then they gave them different dosages. So it's not the same people on different doses. It's actually different people at different dose ranges. So I hope that makes sense. Another person asked, is this a medication patients may have to stay on for life? It is a medication that is meant to be used indefinitely as long as the person is benefiting from treatment. Very similar to insulin for diabetes. Very similar to the lisinopril I take for my high blood pressure. So I know that if I get off my lisinopril and nothing else changes in my life, right? Like I keep the same stressful job that I have, that my blood pressure is always going to be high. So I'll always be at risk for a heart attack or a stroke. So I keep on taking my definitely, right? So yes, the answer is it is a medicine that a person may have to stay on for a very long time. A lot of times patients will give you flack and they'll say, oh God, I don't want to be on this anymore, yada, yada, yada. And I just try to beg them, listen, stay on it. You're doing fantastic. You've got a great life. You're sober. You've got a job. You haven't been in jail in 5 years. Please, for the love of, whatever is holy and sacred to you, stay on this medication. So a lot of times I find myself arguing with the patients to ask them to stay on it. Now, some patients get it, and so they don't give me any problems, and they'll just stay on it. But yes, to answer your question, this is a medicine that can be used indefinitely. And have I ever had a patient that's been on it for 5 or 7 years actually successfully get off of it? I've had 2 people that have done that in the last 18 years. So most of the people that get off of it, within about 12 months, they've relapsed. So that's what I tell people, like, your risk of relapse is so high. If you get off of this medicine, you're better off staying on it. So, but sometimes people need to learn it the hard way, which is awful because sometimes learning it the hard way means you die of an overdose. So I also tell people that, like, it's like playing Russian roulette. So another question, buprenorphine is more for post-stabilization use after an overdose, not for the treatment of an overdose, correct? Correct? Yes, that is correct. So you treat the overdose by waking them up with naloxone and putting them in the ICU and putting them on a respirator, blah, blah, blah. They stabilize, they start to breathe again, you take them off the ventilator, and then you can use the buprenorphine as maintenance treatment for the opiate addiction. So that is correct. It's not something that you use to treat the overdose. Okay, another question is, what is the difference in retention and treatment between bup and methadone? I don't know if I can give you chapter and verse on that. I would say, like, if the retention and treatment for buprenorphine is like 75, then the retention and treatment for methadone is probably 85%. It's still not 100%. So they're very close together. I'd say within 10 percentage points of each other. And then another question was, does the dosage change from patient to patient? Is it dependent on BMI at all or no? Interesting question. I don't think it's dependent on BMI. Yes, the dosage, there's a range. So the useful range of this medicine is somewhere between 4 milligrams a day and 24 milligrams a day. Now there's some interesting political things that happen. One of the political things, which is, in my opinion, super unfortunate, is that in the state of Ohio, unless you get special permission from the insurance company, the maximum that they want you to use in the state of Ohio is 16, which again is ridiculous to me. It's the state government telling me the dose of medicine I can use on somebody, which again really ticks me off bad. So, but in the state of Ohio, they keep it at like 16, and then you have to sort of beg the insurance company to let you go up to 20 or 24. And what a lot of people don't realize, because I'm an old fart, is that back when buprenorphine first came out in 2002, the FDA max dose was 32. So you were allowed to go as high as 32. And then about, I don't know, 7 or 8 years ago, the max dose for the entire country dropped from 32 to 24. So now the max dose that you're allowed to use is 24 milligrams. So there's this ongoing argument in the scientific community. And the argument goes something like this. So there was one article written about 15 years ago, and this one article looked at, let's just say, less than 100 patients. So the one article said that a dosage of 16 milligrams covers 95% of the opioid receptors in the brain. Therefore, 16 milligrams ought to be the dose that works for most people, which is fine, except that then the lawmakers took that and they ran with it, and they started to create all these arbitrary rules. And so people in the world that can benefit from somewhere between 16 milligrams and 32 milligrams, absolutely. It's those people that need that extra coverage of those extra 5% of receptors to stay sober. And I take care of a lot of those people. So I'm constantly arguing with the insurance companies. I love it. So it's my most hated part of my job. So if I didn't have to do that, I could do this forever, but that wears me down. So, yeah, lots of interesting politics about the max dose used to be 32. Now the max dose is 24. The states are limiting you on how many milligrams you can give somebody, yada, yada, yada. But yes, the dosage and what it's dependent on, I think, is a couple things. What is that particular person's brain chemistry? What are their liver enzymes like? And just sort of what is their unique metabolism like? That's what depends on the drug. The other thing that I've noticed is if a person works in a job where they're sweating a lot, there's a very small percentage of the buprenorphine that can come out through the sweat, as well as through the urine, as well as through the bile and stuff like that. So if you work in a job where you're sweating a whole lot all the time, sometimes I have to adjust the dose upwards to account for that. So I've noticed that in my practice. So that's also an interesting question. So, all right. Do the patients that argue with me tend to be people who want to get back into street drugs and are feeling the withdrawal effects of taking other opioids with it? No, it's just people that get sick of having to come see the doctor, of having to fight with the insurance companies. They just want to be free of any drug. And I think, man, if I had to be attached to a drug for life, buprenorphine would be a very fairly easy drug to be attached to, as opposed to being attached to heroin for life. So what I think happens is that people get a little bit comfortable in their sobriety and they start to forget how shitty their life was like 7 years ago when they started to take Suboxone, and their life is so good that they think, hey, everything's cool, I can just get off this Suboxone. And it's not cool, because you'll go back to the old ways. So I think it's people that tend to just sort of get super comfortable in their sobriety, and they think like, hey, everything's great. And what they don't realize is the reason that everything's great because they've had this medicine on board for so long. And is there a percentage of people that just are like, yeah, I want to get back and I want to relapse? Heck yeah. And they usually will start voting with their feet a lot sooner. Like in month 2, month 3, month 4, they'll just fall off the face of the earth. And you know that, and you pray that hopefully they won't die and that they'll come back to you and you can put them back on Suboxone. Okay. All right, more questions. Let's see. Still confused as to why an opiate addiction is treated with another opioid. Yes, great question. So this is, gosh, it came up so early in the talk. So this is the question that I get asked most frequently is, Dr. Delos Reyes, aren't we just treating an addiction with another addictive drug? So that is like the most popular question. Is it a matter of safety after all? So methadone is a lot safer than heroin and less risk of death. That is correct. I wouldn't say methadone is a lot safer than heroin. So one of the reasons that methadone, they're so strict with it and have you come to the clinic like 6 days a week is because it's not that much safer than heroin. Like if you took a whole bunch of methadone, you would just die. Like that's what would happen to you. It would just stop your breathing and you would die, okay? But buprenorphine is like 100 times safer than methadone because of the fact that it's a partial agonist and it plateaus off, which is why you can have it and people can come see you every 90 days because it's like that much safer than methadone. But the confusion as to why you treat an opiate addict with another opiate, I can explain it to you. So I actually have a slide that can explain it to you, which is in a different slide deck. So maybe I'll look for it during the break and show it to you guys. It's super illustrative. But anyways, I'll try to explain it just in words. So basically, what's happening is that the person that's taking methadone or that's taking buprenorphine, they become physically dependent on that medication. So if you were to take them off that medicine abruptly, they would go into withdrawal and feel super duper uncomfortable. However, just being physically dependent on something doesn't mean that you will have all the behaviors associated with the disease of addiction. The disease of addiction is the physical dependence, the tolerance, the withdrawal, in addition to all the negative behavior that goes along with it. What you're doing with the buprenorphine and the methadone is you're giving a person a chance to be physically dependent on something, but to lose all the other symptoms of the disease of addiction, which basically means that for all intents and purposes, they don't have the disease of addiction anymore. All they have is physical dependence on another opiate. So it's the difference, if you understand the difference between physical dependence only and the disease of addiction, which includes physical dependence sometimes, then you understand the point of these medications. So hopefully that gets closer. And if not, I can continue to explain it, and I will look for that slide at the break. What is the cost of, what cost are patients facing for lifelong buprenorphine use? I mean, I think is like constipation and having to be on some sort of bowel regimen. The cost is having to see your doctor 4 times a year. The cost is having to maintain your insurance so that your insurance will pay for it. So insurance does pay for it in 95% of cases. And then I'm not sure I understand your question about, do public health efforts cover the costs? In some cases, there's like grant money and stuff that will cover the costs, but by and large, it's covered by insurance. And then let's see, I also had a comment about arguing with insurance companies is every doctor's least favorite part of the job. Hell yeah. So, all right, does buprenorphine and methadone show up on a standard drug screen? Opioids that don't. Oh gosh, we're gonna do a whole module on urine drug screens toward the end, but just to answer quickly, buprenorphine and methadone do not show up on standard drug screens. You have to ask for them separately. And there are multiple opiates that don't show up on a standard drug screen, and we will definitely get into that. And then there's a question about genetics. Can you check patients for being a super metabolizer with 3A4? Yes, that would be a good way of arguing with the insurance company for a higher dose. How much of the drug cost is covered by insurance? If you have Medicaid, it's 100% of the cost is covered. If you take buprenorphine at 16 milligrams a day, it still costs between $400 and $600 a month. So it's still quite an expensive medication. How do you help patients that cannot afford buprenorphine? Well, I'll try not to get too political, but thanks to the Affordable Care Act, most human beings in the country can now get on insurance that will cover the cost of buprenorphine. So if we keep the Affordable Care Act in place, there should be very, 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 very few people that cannot get their buprenorphine paid for. Another question is, do patients still experience a high when they're on buprenorphine? No, that's the other nice thing about buprenorphine is it's extremely difficult to get high off of it, which is great. Another great question, is there efficacy for using mu receptor agonists for non-opioid addictions? Yes, there's a little bit of efficacy with cocaine, and they're starting to study it. What was the other thing? They're even studying it for treatment-resistant depression, believe it or not. Another question, there is a difference between physical dependence and psychological dependence. That's an interesting, I gotta think about how I want to answer that. Some people believe that there really isn't even a thing like psychological dependence, and so I gotta chew on that one and get back to you. So where can we get more involved about physicians trying to change the laws? Oh, I love this question so much. You can join the American Society for Addiction Medicine as a medical student for free. So as long as you're a medical student, you can be an ASAM member for free. When you are a resident, you can be an ASAM member for 75 bucks. When you become an attending, you have to pay $100. So I always tell people to get in on the ground floor and become I was an ASAM member since I was a medical student. So I've been an ASAM member for 30 some years, and I loved it. So yeah, American Society of Addiction Medicine, www.asam.org is probably a fantastic place to start, because they have like big advocacy arms, and I just love that, because I love the politics of it all. It's one of my favorite things about addiction medicine. So fantastic questions. Wowzers. Okay. And there's other organizations as well. The other fantastic organization, which is not a trade organization for physicians like ASAM is, but if you really want to get into advocacy, I would recommend that you look at a group called Shatterproof. So Shatterproof is to the disease of addiction like the American Cancer Society is to cancer. So it's really awesome. And it's relatively new. It's like less than 10 years old. I mean, we've had the American Heart Association, the American Cancer Society, the American Lung Association, Muscular Dystrophy Association. We've had those things around for decades, but the Shatterproof organization's only been around for 10 years. So, yeah, for break, it is 10:34. I got one more question to answer. For patients coming into the ER for an acute opioid withdrawal, which one is preferred given that there's no contraindications? I would say that the preferred medicine is buprenorphine. It's just a lot easier to use. And the problem is, if you use the methadone and the patient likes it, now you've got to connect them up to a methadone clinic, which you might not have a methadone clinic near you, or the methadone clinic might have a waiting list of 100 people, or the person may not live in a city that's big enough to have a methadone clinic. Buprenorphine you can give nationally anywhere, from the smallest town in America to the largest. So definitely I think buprenorphine is easier to do. So, and yes, you do have to wait till the person is in withdrawal, and we'll talk more about that. So yes, we're taking, Kay, instead of doing the questions now, I'm gonna do the questions as soon as we get back, if that's okay with you guys. So it's 10:35, it's time for our first 15-minute break. So 10:50 is when we come back. And then Kay, if you will start us out at 10:50 with the test questions, that would be awesome, the first two questions. Thank you guys. So I'm gonna stop sharing my screen, and I'm gonna take a little bit of a break. I see most folks are on. I'm going to launch the poll. I don't know what's going to happen because I've never done this before. You'll see 2 questions. So launch polling. Yay. Oh, it looks like, Kay, I get to control it by hitting end polling. Yeah.
That's excellent.
So I'll give it another few seconds. Yeah. Oh, good. Oh, I could see how many people have voted. So cool. Very nice. Gonna wait till I get almost everybody to vote. We're at 65% voting, so almost there. Give it another maybe 10 seconds or so. We're getting close. 75% voting now. I like that. Dude. All right. Oh, 5 more seconds. 135, 136. Okay. Okay, I'm going to call it. We got 93% people voting, so close enough. All right. Oh, now we're up to 95%. Awesome. Okay, so far so good, guys. The first question, you got it correct. Data 2000 is the only thing that allows for the treatment of disorder outside of an opiate treatment program. A was a trick question because what I didn't tell you is that if you prescribe buprenorphine only for pain, you don't need an X number. Oh, tricky. And there's a different set of federal laws that regulate methadone clinics, so it's not the same as what regulates buprenorphine. And D was a trick question because the Data 2000 allows for the treatment of opiate use disorders with Schedule 3, 4, or 5 drugs, not Schedule 2 drugs. So that was tricky. And then for, oh, shoot, I can show you guys. Duh. I'm showing you the polling results. So yes, B was the correct answer, and 57% of you got it correct. And then for number 2, 84% of you got it correct. It is a partial agonist at the mu opiate receptor, and it has, it's the opposite for B. So it's high affinity and slow dissociation from the mu opiate receptor. So that's why that one's wrong. And so that's why the answer is A. So I hope you guys can see the results. Actually, what I'm gonna do, I don't know if this will, because I don't know how else to do it. I don't know how to do a screenshot because I'm not very technologically savvy, but I can take a picture of the poll. Nice. All right. Stop sharing results. Okay. Now let's get on with it. All right. Okie dokie. Very nice. So you've got it. Awesome. Is there a way for us to see the answers you picked? That I don't know. Do you know the answer to that question, Kay? A great question.
We do get a report afterwards.
Ooh.
What's wrong?
Very nice. All right. So let's, I want to finish some of the questions. Don't you have to wait until the withdrawal symptoms are medium to severe before you give them Suboxone due to precipitating a worse withdrawal versus if you give it at the very start of withdrawal? Absolutely 100% correct. That's what this hour and some of the stuff after lunch is going to be about. What is my opinion on Canada's program with prescription heroin where patients can inject in the clinics in a controlled environment? My opinion is that that is what I will call a deep end of the pool intervention. So that is an intervention for the sickest of the sick patients for whom every other treatment has failed. So I would say I'm in favor of it, but I don't think it's something that you should just use as a general rule for everybody. It's a deep end of the pool intervention. So that's what I would say to that. And yes, you guys will be able to see your report, your private report later. Love it. Okay, let me see if I can go back to the slides. All right, Dr. Chris, share your screen. Here we go. Yay. Okay, we were talking about common, I hope you can see my screen. Give me a thumbs up if you can see my screen. Okay. So these are the ways you can manage the common adverse effects of the buprenorphine. This is talking about safety. So what they did was they looked at buprenorphine at different doses from 0 basically to 32. And what they found was that in terms of how badly does it decrease the respiratory rate and how badly does it make the oxygen saturation go down, the answer is not badly, right? So the cognitive effects of being on buprenorphine and the psychomotor effects of being on buprenorphine appear to be negligible, which basically means, yes, you can hold a conversation and drive a car when you're taking buprenorphine, you know, contrary to the way what would happen if you're taking too much Percocet, for example. And the respiratory rate did slow down a little bit, but it had a plateau effect. So it maybe slowed it down from 15 breaths a minute to 12 breaths a minute. So it did slow it down a little bit as you increase the dose. So when you hear about somebody that dies of buprenorphine in their system, 99 times out of 100, it's a combined poisoning, which means that they also had alcohol in their system, Valium in their system, cocaine in their system, and all kinds of other things in their system. So it's not per se the buprenorphine only that killed them. It was the buprenorphine in combination with other central nervous system downers. That's what usually kills people when it involves buprenorphine. Okay, so it is very safe. Okay, so the other thing that I want you guys to be aware of is that when I say the word Suboxone, I probably, number one, I shouldn't be saying it because it's a brand name, but Suboxone is the brand name for a combination drug that's called buprenorphine naloxone. So it's got both drugs in a 4-to-1 ratio. So the drug currently comes in the two sizes of 2 milligrams / 0.5 milligrams and 8 milligrams / 2 milligrams. So the first number is the buprenorphine and the second number is the naloxone. So it always comes in a 4-to-1 ratio. So when this drug first came out on the market, the people were so afraid that people were going to abuse the buprenorphine that they added the naloxone in as a deterrent against IV misuse. So let's see how that works. When you take the buprenorphine in combination with the naloxone and you take it the way you're supposed to, which is underneath your tongue, the bioavailability of the naloxone is so small that it's practically zero. So the naloxone is completely inactive as long as you're taking it sublingually. If, however, you want to try to play games and you want to try to melt down the buprenorphine and mix it with water and inject it into your system, what then happens is that the naloxone part of the medicine becomes activated in the IV state. And now you've got the naloxone fighting with the buprenorphine. And I already told you naloxone is going to win that battle. So the naloxone then throws you into withdrawal. So typically after a person tries to abuse this medicine intravenously, they get a really nasty withdrawal reaction. And so hopefully they won't do it again. So the only reason that the naloxone is mixed in with the buprenorphine is to prevent IV misuse. So the naloxone isn't doing anything to treat the disease of addiction. It's just there as a deterrent against misuse. So that's also important to understand. And so the other thing too is when you mix the naloxone with the buprenorphine, that drug is less likely to be diverted or sold on the streets. So we already have evidence of that. So it is very interesting because a lot of times both clinicians as well as patients, they don't understand the two drugs together. And what they think is that, for example, they'll say something like, well, the bup part of the medicine helps me with my cravings, and then the naloxone part of my medicine is the blocker so that it blocks the heroin. And that's actually not technically correct. It's the buprenorphine itself that both blocks the cravings and knocks the heroin off the receptor. And the naloxone, if you take it exactly the way you're supposed to take it, is pretty much inactive. It's an inactive ingredient. But then when you try to shoot it, it becomes activated. So, so that is another super confusing part of understanding this medicine. Now, you can get buprenorphine as a non-combo formulation. So you can get what is called plain buprenorphine or monobuprenorphine. And the typical reasons for using that are in pregnancy and in some other situations that I will talk to you guys about. But typically when you're prescribing this medicine, you're always prescribing it as a combo drug for the reason of trying to decrease diversion. So that's the way that most people take it, is in the combination. So, but that's the rationale. So something important to understand. All right, so this is basically, again, showing you people that are trying to, I think this is people that tried to shoot the drug. So they tried to show what would happen when you shot the drug. So here, for example, if you look at purple, and they're shooting, with the purple, they're shooting no buprenorphine, and they're shooting a tiny bit of naloxone. And what the person with addiction is saying is, man, that's a bad drug, and I feel sick, okay? If you shoot buprenorphine by itself without naloxone, which is the light blue under B, if you shoot that by itself, the person's like, you know, it's not a bad drug. I mean, it's not a great drug, but it's not a bad drug. And I don't get sick on it. So there are people out there that can be pure IV monobuprenorphine abusers. But as I always tell people, any addict worth their salt isn't going to spend their hard-earned money on monobuprenorphine when they can get high on fentanyl and regular heroin. Why the hell would you spend your money on that crap? It gives you a shitty high. Like, why would you do that? That's stupid. So that's why I kind of laugh when everybody says, like, oh my God, they're diverting it and it's all over the country and yada, yada, yada. The reason they're diverting it is because we created iatrogenically a black market for the drug buprenorphine by limiting doctors to only being able to prescribe to 30 people. That's why there's a black market for buprenorphine. If you let buprenorphine have no limits, the drug deals that involve buprenorphine would drop to zero, because the street value of the drug would drop precipitously, because nobody would want it, because you wouldn't want to. So the vast majority, 75% of the buprenorphine that's bought and sold on the streets is bought and sold because patients don't want to get dope sick. It's not because they want to high, because buprenorphine gives you a shitty high. It's because they don't want to get dope sick. So they use it when they can't get heroin and fentanyl. So if we relax the laws and let there be open access to buprenorphine, we wouldn't have that problem. So then let me show you what happens when you try to inject, in the green, you try to inject the buprenorphine plus the naloxone, which is you try to inject the combo formulation. Now the addict is saying, damn, that's a really bad drug and I'm getting pretty sick off of it. So that's kind of happening. So that's how they kind of know that it works as a deterrent, okay? So, and then let me see. The other thing, let me check my tab real quick here. How long does dope sickness last for addicts if not managed medically? 5 to 7 days. And most addicts cannot stand it for 5 to 7 days, which is why 99.9% of them continue to use drugs and continue to relapse, which is why buprenorphine can stop that cycle of addiction, and you can keep on going. I mean, you can stay well and not relapse. So this slide is about the effect of diversion of buprenorphine. So basically, again, what they're showing you is so this is 240 minutes, so 240 divided by 60. So over a 4-hour period, if you inject plain buprenorphine, which is the blue line, you will get some intoxication, right? You'll get 25 intoxication points out of 100. So that's a really crappy high. Like if you figure 100 is like the best drugs you can buy on the street, you'll get a little bit of a bump of a mini high, but then it kind of fades away. And then if you inject naloxone, you're not getting any high. If you inject placebo, you're not getting any high. If you inject the combination, That's the B. The yellow, again, it's really cruddy. It's really crappy. So yes, you could become a buprenorphine, a plain buprenorphine injector, but why? There's so many other better drugs on the market. So anyway, I mean, plus the buprenorphine you buy on the street is probably 5 times more expensive than the heroin you buy on the street. So you're really wasting your time and your money. So anyway, see, I think that lawmakers, they don't understand how people with addiction think. And so they come up with all this crazy stuff. And it's like, that's not how people think. You got to work with these patients and ask them these questions, and then you'll know. So anywho, sorry, I digress. All right. So here's the famous question that some of you were getting to. So buprenorphine versus placebo versus methadone. So there was a Cochrane review of the 31 trials, 5,400 participants. Buprenorphine is an effective medication for retaining people at any dose above 2 milligrams. So you need a little tiny bit. You need at least 2 milligrams. And it can suppress illicit opioid use at doses 16 milligrams or greater. Buprenorphine appears to be less effective than methadone in retaining people in treatment. Remember, we were talking about treatment retention, but I think that one might be a little bit of a misnomer because they were using very low doses of buprenorphine. So they were using 2 to 6 milligrams per day. So I think if you used a dose of 8 to 16 milligrams a day, or 8 to 24 milligrams a day, or 8 to 32 milligrams a day, we start to see comparable efficacy methods of retention. So, that's exactly what the third bullet point says, which is that if the buprenorphine is at a higher dose, 7 milligrams per day or above, that's actually not different than methadone prescribed milligrams or above in terms of retention. So it's dose dependent. The retention is dose dependent. All right. Buprenorphine plus benzos. So benzos are like Valium, Ativan, Klonopin, Xanax, those types of drugs. So they're addictive anti-anxiety medications. So when you read in the literature that somebody died of buprenorphine, like I told you, 90% because there was something else on board, and that something else is typically the benzos. So, so benzodiazepines have been found in most fatal poisonings that involve buprenorphine. So when they looked at human studies, there were minimal effects on breathing when both medications were taken at therapeutic doses. So if, for example, I give somebody Valium 10 milligrams twice a day, and I give them Suboxone 8 milligrams twice a day, that's both therapeutic doses, then typically there's minimal effects on respiration. But when they looked at animal studies, what they found is that when you mix the benzos with buprenorphine, that ceiling effect or that plateau effect could be removed, and then that could then allow the buprenorphine to produce fatal respiratory suppression and overdose. So what the bottom line is that when you use benzos as prescribed, it does not interfere in terms of mortality and safety or treatment outcomes, but it has been associated with more accidental injuries. Definitely caution that you must take when you're thinking about co-prescribing buprenorphine and benzos. I mean, what I tell most people starting out, like if you're going to do your first 30 patients when you get your license, don't be, playing cowboy or cowgirl and mixing your buprenorphine with the benzos. You might want to wait until after you take like an addiction medicine fellowship to do that, or after you've been at it for about 10 or 15 years, then you might feel more comfortable, but don't do it with your first 30 patients, I guess is my unsolicited advice to you guys. So interestingly, the FDA had some interesting opposite recommendations, which kind of showed you how ambivalent the country still is about buprenorphine. So back in 2016, in the summer, there came out a boxed warning, and a boxed warning is like the most serious warning that the FDA can put out about a drug. So there came out a boxed warning that said, oh my gosh, you can't mix opioid medications with benzodiazepines or other CNS depressants, which is like, yeah, duh, because you'll have slowed breathing, difficult breathing, sedation, and death. So this included things like, buprenorphine. So then everybody in the buprenorphine world was all like, oh my God, we can't do this anymore, yada, yada, yada. 13 months later, in September of 2017, kind of backtracked on their own opinion, which I love. I'm like, oh my gosh. So this just tells you that you have to keep on learning, and now it's 2020, and then it's going to be 2020. The research and the recommendations will continue to change as we get better data. So 13 months later, they sort of said, well, we're going to take it back a little bit. Buprenorphine and methadone should not be withheld from patients taking benzodiazepines, because even though the combined use of these drugs increases the risk of serious side effects, the harm caused by not treating the opiate addiction to very serious side effects like death. And so we think maybe it's okay to do it. And then they said, just be careful. Careful medical management, care professional can reduce these risks. So that's just to say that even the government is flip-flopping on their opinion. And so you got to watch the news carefully, and you got to watch the FDA website carefully. So just, yeah, this stuff doesn't stay still. So what the FDA said is, in order to do it carefully, here's some of the things you can do. If you're going to combine buprenorphine with a benzodiazepine or something else that is a CNS depressant, you should, of course, educate your patient and document that you educated the patient about it. You can try to taper the benzo down to the lowest possible dose, or taper it to continuation. You can verify the diagnosis of anxiety or insomnia that they're asking you for the benzo for. You can recognize that patients might require MAT indefinitely, and that use should continue for as long as patients are benefiting. You should coordinate care with other prescribers to make sure that, you know, the primary care doctor or the main doctor isn't giving them all these other medicines while you're trying to treat them with buprenorphine. And then, of course, you have to do urine or blood screening to monitor for other drugs. So basic recommendations. I think there's nothing earth-shattering there, but it's just ways to do it safely. So if you're going to do it safely. What about buprenorphine and alcohol? Well, certainly the overall recommendation is to avoid anything that's a CNS downer with buprenorphine. But of course, you're not going to be following your patients around or putting an ankle bracelet on them to make sure that they don't drink, right? Because you can't possibly do that. So all you can do is teach your patients that buprenorphine plus alcohol, not a good mix. And interestingly, as well, question, are they studying buprenorphine for other drug addictions besides opiates? There is a little tiny bit of evidence out there that for some people on buprenorphine, it can also help them decrease their craving for alcohol. Like, that's fascinating. And then the other thing, which is sort of the opposite, is that we know that has alcohol use disorder or is a bona fide alcoholic, that person has an association with having a higher rate of relapsed opiate use, which again is kind of like a no-brainer, like, yeah, duh, of course they would be at higher risk. So, because they've got two addictions instead of one. So that's sort of the story on alcohol. I mean, I always tell my patients, look, you shouldn't be drinking while you're on it. Once in a while, the patient will come back and tell me the truth, like, yes, it was the 4th of July, you know, I had 1 beer, 2 beers, okay, you know, what am I going to do? Like, take them off their buprenorphine? No, I'm not going to take them off their buprenorphine. They just need to sort of be warned and educated that that's generally not a good idea. And, you know, cut that out kind of thing. All right, so we talked already at length about diversion. So buprenorphine certainly has the potential for intravenous misuse. But as you've seen on some of the slides, number one, why would anybody waste their money on that? And number two, it's like expensive. So you're wasting a lot of money on a crappy high. Okay, but yes, does it have potential for misuse? It absolutely has potential for misuse. So there's a lot of research out there that says that tablets are more likely to be diverted than films. So it comes in a pill form, it comes in like a Listerine strip kind of form that you melt under your tongue, and that the monobuprenorphine products are more likely to be diverted than the combo drug. All that makes sense. So what they did, which was interesting, is they surveyed patients that were in Suboxone programs across the United States, and they looked at, you know, they asked them questions like, how many times have you, you know, diverted the drugs or whatever, and so they found that if you used the film as a reference and called it number 1, the tablets were, you know, twice as likely to be diverted because the diversion rate was 2.2, and the plain buprenorphine tablet was 6.5 times more likely to be diverted, because you can take the tablet and you can crush it and you can shoot it. So yes, the answer to the question is the tablet is more divertible than the film, But then when you think about what's the actual harm that's coming to people, honestly, I'd much rather have people shoot buprenorphine than shoot heroin, so less likely to die. I mean, no, I don't want them shooting buprenorphine, but given the choice, yes, it's safer. So that's why the combination product is the standard of care for general use. So you should not be out there monobuprenorphine to all of your patients, right? So, but here's the rub. The monobuprenorphine generic is 4 times cheaper than the combination product. So then you start to get into copays and crappy insurance coverage and all these other things. And so sometimes patients are forced into getting the plain buprenorphine because that's what they can afford. And so again, that brings up another interesting issue. So realize that dynamic as well. Also realize that even though the naloxone in the combination is supposed to be basically, you're not supposed to be able to feel it, some patients are still very sensitive to it. Now, those patients that tell you, I can't stand the naloxone in the combo prep, doctor, you're going to have to give me monobuprenorphine. Half of those patients are pulling your leg and they're just trying to get something that they can sell on the street. But half of those patients, I think, are legit. So you are to make the judgment call. So you can decide, nope, my entire practice is always going to be the combo formulation. I'm not going to give out the mono formulation. Some of you may decide, well, I'm not going to give it out very frequently, but I will give it out if there's a particular or a special case. So anyway, all right, I think I see a couple questions piling up here, so I'm going to try to answer some of them. All right, here we go. Yes. Continue the political tangents. We don't get to hear enough about this stuff. Oh boy, you're going to be sorry you said that. Oh, are people more likely to agree to try buprenorphine or methadone? I would say people are more likely to agree to try buprenorphine because once they hear the stuff about methadone and how you have to go to the clinic 6 times a week for like 6 months and then how you have to slowly earn a take home, they're like, dude, I don't want to do that. So, so yes, that's the answer. That's the quick answer to that question. All right, what other questions do we have? Due to the QT prolongations, you have to be careful with the Suboxone. You know what? It's funny, when you give out Suboxone, there's not even a, well, actually, excuse me, the QT prolongation is with methadone. So Suboxone does not have significant enough QT prolongation for them to even tell you to check an EKG. So checking an EKG is not one of the prerequisites. But I think that checking an EKG is becoming one of the prerequisites for methadone treatment. But the answer is, if I changed the word Suboxone in your question to the word methadone, then yes, due to QT prolongation, you would have to be careful PCAs with methadone. But I don't think you have to really have that much caution when you're co-prescribing it with Suboxone. When will the generic become available of Suboxone? There's been generic Suboxone for years. So we've had generic Suboxone film and generic Suboxone tablet, I'd say, for about 7 or 8 years. And there's about 12 different kinds. So if films are less likely to be abused, why are they not prescribed instead of tablets? Cost, 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 cost. It's always cost. So what happened was the generic tablets came out 5 years before the generic films came out. So now that the generic films are out, the cost is slowly starting to come down. But as far as I know, the generic films are still more costly than the generic tablets. All right, can you prescribe naltrexone buprenorphine as 2 separate strips and instruct the patient to take like Suboxone? No, they don't have it. It only comes in the plain buprenorphine form or the combo form. It doesn't come as 2 plain forms that you can mix together. No. So how do I decide between prescribing the films and the tablets? I basically have to go by what tells them. So 95% of the time, I will start them out on tablets. And then if they don't tolerate it, then I will petition the insurance company to pay for the films. And again, it depends on which insurance company you're dealing with. So, you know, back in the olden days, everybody got films because there was no generic tablet. Now everybody gets tablets, and only in special circumstances do I ask the company to give them films. The other difference between the films and the tablets is the films will disintegrate in your mouth in 5 minutes. The tablets, unfortunately, can take up to half an hour, even though when you read the product description, it's only supposed to take like 10 minutes. But my patients will say they got to sit there and taste that nasty taste for like a half hour, and they hate it. So that's another reason why people after 7 years, they get sick of it and they're like, take me off of this stuff. So yeah. All right, so we're going to spend a few minutes talking about naltrexone. Again, this is also political because this is supposed to be all slides about buprenorphine, and politics got in there because I think the naltrexone drug company said, damn, you know, all these people are getting trained on buprenorphine and our product isn't being talked about. So now they make me talk about naltrexone, but it drives me crazy because this is probably the 20th or 25th time that I've given this training, and there were never any naltrexone slides before. See, my problem is I'm too old. I know the history. So be that as it may, naltrexone is a long-acting, high-affinity opiate receptor blocker, which also has an active metabolite. When you have good plasma concentrations, it fully blocks all opioids. So it is approved for the treatment of opiate use disorder. The problem is that people don't take it. So here's the conversation you're having with an opiate addict. Okay, opiate addict, I'm going to give you something that totally blocks all effects of opiates. You know, and the opiate addict looks at you like, you know, say what? You know, and so they don't like it. And so if they want to get high, they just stop taking the pill. So it wasn't until 2010 that the Vivitrol shot came out. So now they can't not take the medicine because the probation officer or the judge says you have to take this Vivitrol shot in your butt or else you're going to go to jail. So which one would you rather have? You know, nothing like coerced treatment, right? So, you know, you prisoner with no rights, you know, we're going to force you to take Vivitrol, you know, or else go to jail. So they take the Vivitrol and then they can't feel anything for 30 days. Okay, fine. So that's how they do it. But given their choice, most people would say, well, I don't want that. I don't want the shot or the pill that's naltrexone. I would rather have the Suboxone because the Suboxone is at least partially turning on the opiate receptor, giving them a little bit of juice, right? I mean, that's what you want. So anyway, that's just my opinion. There's lots of judges, lots of parole officers, lots of traditional treatment providers that sometimes look upon buprenorphine as like pure evil, and they say, well, we shouldn't be giving controlled drugs to people with addiction, you know, because they don't understand the difference between physical dependence and the disease of addiction. And so because of that, they misunderstand everything there is to know about buprenorphine. So anywho, so once they came out with an naltrexone injection, they started to get better compliance. And yes, it is an appealing choice for anybody that prefers to not be on any opioids. So yes, there are patients that are like, I don't want Suboxone, just give me the shot. Fine. So you can give them the shot. There's that option. All right. So this is just showing you that naltrexone is efficacious. Well, obviously it wouldn't be FDA approved if it wasn't efficacious. So it does give you opiate-free urines. So the naltrexone is on top of the placebo line. It does decrease your craving score. So here's the very low cravings with the naltrexone and then regular craving scores with placebo. And it does retain.
Hello.
Yes. Yes. Oh, okay. Sorry. I thought I heard somebody trying to talk. And then again, it does retain people in treatment. So yes, it definitely works. Let me get back in there. All right. So naltrexone works either by behaviorally causing extinction. So if you're on the shot, you can't feel any heroin. Eventually, you're going to extinguish the heroin behavior because you're not getting any high from heroin. But it also can work by a pharmacological mechanism by decreasing craving. So then it, you know, decreases the chances that you'll use it. So again, naltrexone is like the third tool in our toolkit. So we've got buprenorphine, we've got methadone, and we've got naltrexone. So we've got 3 tools in the toolkit to help people with opiate addiction. So what's the effectiveness of the buprenorphine versus the injection naltrexone? So there's 2 comparative effectiveness trials that have been done in the world, one in Norway, one in the United States. The overall findings are that once the medicine is started, both medicines are comparably effective, although they did admit that the buprenorphine doses were not maximized in the trials. And what they also found is that naltrexone is much more difficult to initiate because you have to get the patient through medically supervised withdrawal. So the biggest problem with getting people on naltrexone is that you have to be opiate free for 7 to 10 days. Well, dude, if the person could stay opiate free for 7 to 10 days, they wouldn't even be coming to see you for treatment, right? They would just sort of use their opiate like 3 days a month, right? They would just kind of like chip away. But the problem is that the opiate addict can't stay off their opiates usually for more than 24 hours. So you have to put them in a controlled setting. You have to safely get them off of the heroin, and then you have to keep them heroin free for 7 to 10 days before you can start the shot. With buprenorphine, you can get somebody from heroin use to 12 hours after heroin use to 24 hours later, they're totally stable. That's the advantage. So that's what is the bugaboo about the naltrexone. Like I literally would put everybody on naltrexone if I didn't have the 7 to 10 day waiting period, trying to get them to be sober using for 7 to 10 days while I'm waiting for the, you know, for it to be safe enough to give them the shot. So that's the problem. So anyway, plus there's some problems also from a psychiatric standpoint, because the naltrexone in a certain percentage of people also makes people suicidal. So they don't ever tell, the drug rep don't ever tell you that. So I don't listen to drug rep. Okay. So yes, so the naltrexone says you have to have an opiate-free period of 7 to 10 days in avoid precipitated withdrawal, and that is challenging because you have to tolerate the awful withdrawal symptoms and remain abstinent for 7 to 10 days. You can certainly give people comfort meds for withdrawal, like clonidine. Again, there's an ideal setting for naltrexone would be like residential treatment, but again, because of insurance problems, it's hard to get somebody into residential treatment. So they are trying to fool around rapid methods for getting a person onto naltrexone. And so I've read papers where they can do like, they can kind of do some, you know, goose it a little bit and get the person on in 4 days instead of 10 days, you know, so there's different things you can do. I'm not saying it's impossible. I'm saying it's inconvenient enough that I don't do it as much, is what I'm saying. All right. So again, treatment advances with naltrexone, unless you're using the shot. There are some people that will experience low levels of withdrawal after the first shot, but usually after the second shot, that kind of resolves and they start to feel better. And then you can also have injection site reactions. Typically it's soreness, but you can get, if you don't give the shot correctly, you can actually get necrosis of the gluteus maximus muscle, and now you've got problems, and now you've got to call the surgeons in. So sometimes it's problematic with using the shot. So you got to be very careful about giving the shot correctly, make sure that, you know, they don't develop necrosis of their butt muscle. So anyway, so, and then the other big thing too is if the patient decides not to show up for their shot, what you've now done is you wiped all their opiate receptors clean of everything, and they're actually at higher risk of overdose and death in the first 30 days off of their shot than they were when they were like full-blown using heroin. That's the other thing that scares the crap out of me when I have that thought with my naltrexone patients is, what if they don't come back and get the next shot? Now I've kind of left them hanging with that, with like nothing on the receptors. At least with the buprenorphine, I know that there's medicine sitting on that receptor that will at least give them something so that they don't feel like they have to go right away to the heroin. So definite things to keep in mind. Okay, so here's like just a grid that sort of shows you side by side the 3 drugs. So as you know, methadone is the full agonist, buprenorphine is the partial agonist, naltrexone is the antagonist. The usual dose of methadone is 80 to 100 milligrams per day. The usual dose of buprenorphine is 4 to 30 milligrams. Although you guys now know that the actual new FDA maximum is 24 milligrams a day, so you can cross out the 32 and make it say 24. And then the naltrexone is 380 milligrams IM injection once a month. Again, it tells you some of the advantages and the disadvantages. The advantages for methadone is you got highly structured setting, and then it might be effective for people that don't do well on buprenorphine. The biggest advantage of buprenorphine is it's super duper easy to do and it's super duper safe. And then the biggest advantages of naltrexone is it is not a controlled substance and it is not addictive, and it's good for people that want to avoid any opioids. So, so that's our 3 forms of MAT, or medication-assisted treatment. We do know that treatment with MAT does improve retention and decrease use of illicit opioids. The short-term treatment, where you take away their MAT after a brief period of time, like after 4 to 6 weeks, that's really not a good idea. And then pharmacodynamically, When you combine methadone or buprenorphine with other downers, that can increase the risk of sedation or respiratory depression, and the risk is highest with benzodiazepines, particularly when you do IV benzodiazepines. So if there was a question, and I'm not saying there is a question, but if there was a question saying which combination is the most dangerous combination would be IV benzos plus IV buprenorphine. That's a very dangerous combination. But if you're just giving somebody sublingual buprenorphine and oral benzos, your risk is much less. So just wanted to let you know that. So, references there. So now we'll get into patient evaluation, but I just want to check real quick that I haven't missed. Oh, the craving score. I don't know enough about the craving score to tell you. I would actually have to look that up. But the craving score is very, from my understanding, it's very simple. It's like a Likert scale between 0 and 100, and then they just ask the patient to rate their craving. So it's that simple, I think. So the only criteria is you just telling the patient to rank it. So that's my sort of poor woman's explanation. There might be more to it, but I don't think there is. Are there do's and don'ts with the injection technique related to gluteal necrosis? Yes, there's an entire like 48-page monograph that tells you exactly how to do it so you don't mess it up. It comes with a special needle. You have to let the medicine come out of the fridge into room temperature for 45 minutes. You have to mix it up very carefully. You have to mix up the little white beads with the liquid that they give you. You have to mix it very thoroughly. And you have to inject it like right away. You can't just let it sit there because it'll disintegrate again instead of being more like a suspension. And so there's all kinds of things. There's all kinds of techniques. And then I think you have to use this technique called like the Z-line technique or something for giving injections. Again, I don't give injections as a rule. So there are techniques. So yeah. So thank you for those great questions again. All right, so this next set of slides is sort of when you're actually starting to give somebody buprenorphine, some of the rules and how to do it. Some of this stuff is gonna seem like really silly. So pardon that because that's just the slides I have to give you. Like this is what I always say when I teach this class. If I have to sit up there and tell you that you have to have a non-judgmental, curious, and empathetic attitude and you're third-year medical students, it's too damn late for y'all, right? Like that's stuff you need to have learned like when you were like 12 years old, right? So the attitude of when you're working with people is not something that I should have to put on a slide. But unfortunately, because of the stigma associated with the disease of addiction, and particularly the stigma that comes with being an opiate addict in this country and in many other countries, I do have to say stuff like that. So to me, the slide always makes me sad because there's a lot of people that treat people with addiction judgmentally and very unempathically. So that's why we have to make a point of saying it. It's also helpful if you're respectful. Really? Yeah, respect, that kind of helps. So you have to recognize that the person has strengths. It's helpful to use non-stigmatizing language like, please don't call him like, right? Or, like a street addict or something like that. You might want to say, a person with a substance use disorder or a person suffering from opiate use disorder. Some people even say that the word addict is bad. I use the word addict because that's the way I was raised, and so it's hard for me to say that. So instead of saying addict, you could say person with a substance use disorder or person with addiction. Addict is short. So, doctors, we don't have a lot of time, so we like to shorten shit up sometimes. But yes, just be aware. So you might want to think about person first language, avoiding the words addict, junkie, dope fiend, bad. Don't say those things, right? So try to get out of the non-stigmatizing language. Honesty, again, if 20-something years old and I got to tell you to be honest, we got a lot bigger problems than buprenorphine training. It's helpful to have shared goals, like why is the patient seeking treatment, what concerns do you have as the treatment provider? Reassurance, again, you want to assure the patient that you're concerned about their health, that there is going to be confidentiality with qualifiers. So and if the person's up there saying, yes, I'm a heroin addict and I'm suicidal and I want to die and I want to take people out with me, well, obviously confidentiality goes out the window. You know that, or you're about to know that from your psychiatry rotation, that there's a duty to warn and you've got to pink slip the person if they're suicidal. So yes, the confidentiality is there to an extent. So a lot of times it's helpful to tell the person up front, like, you know, yes, what you say in here is confidential, with the exception of you threatening to hurt yourself, hurt other people, or if I find out that in some situation child abuse is going on, then I'm a mandatory reporter and I've got to do something about it, right? So you can tell them that up front. And again, it's about safety and the well-being of other people, especially kids. So with that caveat, you can have your conversation. What you're trying to do with your visit with the patient is you probably want to be looking at the ORS report first. So the ORS report is Ohio's version of the Prescription Drug Monitoring Program. So you guys live in a world where there's always been ORS reports. So back in the day, like old people like me, a patient could go from pharmacy to pharmacy to pharmacy and get like a different opiate prescription filled at 5 different pharmacies, and none of the pharmacies any the wiser. Now we have the ORS program, so you can see for every controlled substance that's prescribed in the state of Ohio, you can see exactly what day they picked it up, how many they picked up, what milligrams they picked up, the name of the pharmacy that they picked it up on, and you know the quantity. So you can see everything. So there's absolute transparency with regards to controlled substances in the state of Ohio. So it is a super duper useful tool that you should be checking every time a person comes in to be treated with this drug, because then you, oh yeah, they picked up 100 Percocets last week, and now they're saying, I don't have any Percocets left on me. Well, then that tells you something. Either they ate all 100 Percocets in the last week, or they ate half of them and they sold half of them. At any rate, they're out, right? So that's what happens when you get addicted. You take them or you sell them. So you want to be looking at your prescription drug monitoring program just to make sure that everything's on the up and up, because sometimes people like to tell you tales. So not that they're liars or dishonest, but they have the disease of addiction, and their disease is trying to keep them sick. At least that's just the way I look at it. You got to get them to fill out tons of paperwork, like a consent for treatment and a release form to talk to their other prescribers, treatment agreement. None of this stuff has to be invented by you. If you go to this website, the PCSSnow.org website, you will have all the clinical tools that you could possibly need to start treating somebody with Suboxone. So I won't belabor that point, but just to say that you don't have to do that part of the work. It's already been done. It is helpful to get that initial drug screen on your patient. So you can do what's called point of care testing. So point of care testing is when you have a little cup, they pee in it, you wait 3 minutes, and then you peel back this layer, and then it can tell you which drugs are positive and which drugs are negative. That's a point of care test. It is not considered gold standard. Its gold standard is to send a confirmation test to the lab. So there's advantages and disadvantages. The main advantage to the point of care testing is you can see what's happening right away within 3 minutes. The main disadvantage of point of care testing is there's a lot of false positives and false negatives. So it ain't perfect. So that's why my practice is almost 100% confirmatory testing. So I get them to pee in a cup, I send it out to the lab, I have to wait a day to get the initial results, and then I have to wait 5 days to get the confirmatory results. So a lot of times what I do in my practice is if I'm starting somebody on the drug, they'll have to see a nurse a week before they see me. So I'll have all that stuff ready to go when I'm in the visit with them. Or you could just do a point of care test. But just realize that the point of care tests are not 100% accurate. That's what I want you guys to take away. And the point of care cups, they don't test for everything either. And the labs may not test for everything either. So you're going to get to be very good friends. If you do this kind of work, you're going to get to be very good friends with the toxicologist that runs the lab, because you'll just kind of be calling them for questions and stuff. So you send confirmation testing on every new patient, and you send confirmation testing when you get a positive point of care test. And then you also have to do other testing, like make sure they're not pregnant, and also test for other drugs like fentanyl or methadone or buprenorphine. So not everything is tested by the little pup. So that's part of the problem. All right, you got to take a medical history. You guys are medical students. You know how to take a medical history, but you take the same medical history that you would take in any other patient. I think what you would focus on is bullet number 3. What's the relationship of their medical symptoms to their substance use, right? You know, what medications are they taking, you know, and then check their labs. So it's same old stuff that you do. It's important to take a psychiatric history. Again, it doesn't have to be full blown like if you're a psychiatrist, but at least it's helpful to figure out like symptoms symptoms before they started using drugs or after they started using drugs? That's a helpful question. What is their trauma history? Super duper question. And somewhere between 80 and 90% of your opiate addicts will have had a history of trauma. A lot of it's severe. So always ask the trauma question, and then ask them, what kind of treatment have you done? Have you been in residential treatment? Have you been in IOP or PHP? Half of this stuff is just learning the lingo. So IOP stands for intensive outpatient program, and then partial hospitalization program is PHP. The only difference between IOP and PHP is intensity, because by law, IOP has to be 9 hours per week in the state of Ohio, which is why most treatment centers are set up like 9 to 12 a.m. or 1 to 4 p.m. Monday, Wednesday, Friday. That's how most treatment centers are set up, because they know in Ohio they got to do 9 hours a week in order to be licensed as an IOP. And then partial hospital programs are a minimum of, I hope I don't get this wrong, is it 20 hours a week or 30 hours a week? It might be 30 hours a week. Like you literally have to keep them there all day. So you have to keep them there like from 9 to 3, like 5 days a week. So PHP is much more intense. So you can ask the patient, have they ever been through those programs? And then you want to ask them, like, what psych meds have they ever been on? Social and family history, again, same thing. This is where you'll start to see some of the fallout from their addiction, is in the social and family history. So kind of like, what was their growing up like in the home? You know, did they finish school? Do they have a job currently? You know, what's their relationship status like? Are they homeless? You know, do they have a good sober place to live? What's their legal status, and what kind of things are kind of stressing them out? And then again, very important, collect the family history, because a lot of people have a positive family history for addiction and other psychiatric conditions. So it's fairly simple stuff. And then of course you got to get into the substance use history, so the patterns of use. So if the person only is a heroin addict, then they've got one drug to talk about. But most people are polydrug users, so you have to talk about every single class of substance, starting with cigarettes, prescription opiates, non-prescription opiates, heroin, fentanyl, and all the other opiates, alcohol, marijuana, uppers, downers, all arounders, you know, mushrooms, PCP, LSD. There's lots of drugs you have to ask about. So if you're going to do a thorough assessment, you should be asking about all the drugs. So it can take a while. Now, like I said, if they're just a pure heroin addict, then this part of the conversation is short. But this part of the conversation you can stuck for quite some time. Because with every drug that they've used, it's important to know or to have some idea about how old were they when they started, what's their pattern of use, what have they been using over the last few weeks, and what kind of cravings do they have for that drug, and do they think that they're addicted to that drug? So you times that by 10 classes of drugs, that could take you a while to ask all those questions. And then you want to ask them, you know, what happens if you try to stay off of the drugs? You know, do you go into withdrawal? What helps them to stay sober? What's the longest that they've ever been sober from X, Y, ABC drug? What are their most common things that cause them to relapse? I'll tell you the quick and dirty answer is it's always people, places, or things, right? So it's people, places, or things that cause you to relapse. So as you're listening to them talk about the relapse triggers, you can subdivide it into those 3 categories. So it's either you're hanging around with the wrong people, you're hanging around at the wrong places, or you're doing some of the wrong things, as was illustrated by my patient this week, who I've had on buprenorphine for like 1.5 years. He hasn't used opiates in 1.5 years, thank God. He's like 30 something. And he goes, Dr. Chris, I messed up. I said, oh, you know, tell me more. What did you mess up on? And he said, well, I messed up on alcohol and cocaine. And I'm like, oh, tell me more. It's like, well, I was kind of hanging around with the wrong people. I'm like, oh, okay. And I was kind of at a strip club. Oh, okay. So, you know, the story, they're not going to tell you the whole story at once, but eventually the story is going to come out. So, dude, what are you, a dude that's trying to be in recovery, doing, hanging out at a strip club with the wrong people, you know, using crack and alcohol? No. People, places, and things. Not the right thing to do. So, yeah. So, come on, man, you know better. Like, what are you doing? Plus, he's on probation, so now he's looking at going back to jail. He's looking at losing his son. I'm like, what are you doing, dude? He knows better than that, right? But people, places, and things, they'll get you every single time. Every So yeah, no more strip clubs, coke, and alcohol for you. Yeah. And then you want to look at what is their response to treatment. Are they familiar with AA and NA and other 12-step groups? And did they like AA or did they hate it? So I conversation of, hey, have you ever been to a 12-step meeting and did you love it? Did you hate it? Did you find it helpful? So there's different answers that you'll get to those questions. I mean, sometimes you'll meet people in AA that are like, AA is the only way to get sober and you have to have a higher power and you got to do this and you got to do that. Yeah, it is helpful for millions and millions of people, but it may not be for everybody. So I always have some mental flexibility around that, that AA may not work for everybody. It sure does work for a hell of a lot of people, but it may not work for everybody. And again, I'll link to that. And then again, you want to look at what were the effects of the drug use in their life. You want to ask specifically about tolerance, intoxication, and withdrawal. You want to look at the consequences of their using. And like I said, as you take your social history, you can certainly hear about the consequences of their use because it's like to describe it. It's like a tornado. Addiction is like a tornado. Like it comes into somebody's life, spins around, causes all kinds of chaos and destruction. And you can see the chaos and the destruction in terms of medical, legal, family, psychiatric, job, and other consequences. So yeah, you can sometimes see that that tornado has been spinning around for lots of years for lots of patients. So definitely it's pretty awful. You have to get your DSM-5 criteria right because one of the first things you have to do in order to prescribe buprenorphine is you actually have to have a bona fide diagnosis of opiate use disorder. Kind of like a duh kind of moment, but just to let you know that there's 11 criteria for addiction. These are the 11 criteria right here. So there's loss of control criteria, there's physiologic criteria, and then there's consequences of criteria. And a substance use defined as having 2 or more of these 11 symptoms in the past year. So it's pretty low bar, right? And with the caveat that if you only have your 2 symptoms as tolerance and withdrawal, that is not necessarily a disorder. So one of the things I hate about the current criteria is there's this big asterisk that says, if you only have tolerance and withdrawal because you're getting a controlled substance legally from a doctor and you're taking it properly, then you don't count the tolerance and withdrawal towards an addiction diagnosis. Like that's literally what you have to write. That's the big caveat. So because the problem is if 2 symptoms were enough, then anybody that is taking Percocet for their back for many years, but not running into any trouble with their Percocet would be considered as having an addiction, and they clearly don't. That's what I was trying to explain to you guys before about the difference between physical dependence and the disease of addiction. So the criteria, we still got problems, but it's better than it was, believe it or not. So 2 to 3 symptoms are considered mild substance use disorder. 4 to 5 symptoms are considered moderate substance use disorder. And if you have 6 or more things on the list, that's considered severe substance use disorder. And these are the exact same criteria for every substance. So this can be opiates, this can be cocaine, this can be alcohol, it doesn't matter. So it's just the DSM-5 criteria for substance use disorder, and then you just look at it substance by substance by substance. So once you've established the diagnosis of opiate use disorder, now you've actually got something that you can treat with buprenorphine. But first things first, you got to have the diagnosis first. So physical exam, some can see these things on physical exam. You're not always going to see track marks. You're not always going to see like skin popping. Depending on when you see the person, their pupils can be large or small. If they've got yellow eyeballs, they're pretty far along. You know what I mean? So some of these things are not like sort of as relevant when it comes to opiate use disorder, because a person can have a totally negative physical exam, have an opiate use disorder. So I want you guys to know that as well. Like I told you, a lot of them have bad teeth. Some people might have heart disease from endocarditis, that kind of thing. Some people might have an enlarged liver from hepatitis C. But again, that's just a smattering of physical symptoms. It's more of a clinical diagnosis than it is like you're looking for something specific on physical exam. Really not. The most specific thing is probably like the abscesses and the track marks. That's probably the most specific thing that you'll see. Laboratory testing, you should get the pregnancy test for women of childbearing age. Obviously, get your urine drug screen. This is recommended to get these other things. Always check your hepatitis. I don't know why they say hepatitis C and A. You should be checking for hepatitis A, B, and C. But anyway, get your liver function test and get a CBC. In the state of Ohio, it's actually mandated by law to get certain tests. Not true in other states. So just FYI. Here's some things to consider when you're trying to figure out, is this person suitable for office-based opiate treatment with buprenorphine? Can they follow treatment recommendations? This list cracks me up. Do they have stable and supportive psychosocial circumstances? You know, are they taking medications that can interact with buprenorphine? Are there available resources in your office? Who's on call? Are there treatment programs that are available? And I just think about the psychosocial circumstances of almost all my patients when I first meet them is very unstable and unsupportive. So this is sort of like, find me the perfect person for Suboxone treatment and I'll treat them. And I'm like, I don't get any of those perfect. I don't know where they hide, but I certainly don't get any of these perfect people coming in for Suboxone treatment. They must be going to other providers, not me. That cracks me up. At the first meeting, so again, as I was saying, you can set up your clinic any way you like, but as I was alluding to, sometimes you want to have the patient see one of your nurses or see one of your counselors first, and then a week later have the doctor's appointment so that you can tell them all these things, all the rules, right? Like, you're not supposed to share your medicine with anybody. Don't sell your medicine to anybody. Don't continue to use drugs and alcohol. If you're getting any other medicine from any other doctor, you got to tell me about it. You have to store your medicine safely. You don't usually have to tell patients with their medicine. But for Suboxone, yes, they should be buying a little safe with a little lock on it, or you should have a place where kids can't get to it, pets can't get to it, and nosy neighbors and other people that have addiction in their life can't get to it. Because I can't tell you how many times people get their buprenorphine stolen, mostly because of what we set up as the system for only being able to treat 30 patients in the first year, plus that it has street value. So anyway, got to keep the medicine safe. And then you have to figure out, if they're using other drugs, are you as a Suboxone prescriber going to feel comfortable with it? So if the person has an alcohol problem, a marijuana problem, a cocaine issue, should you be starting them on buprenorphine? So obviously, if they drink a lot of alcohol, you should caution them to avoid it. If they've got really severe alcohol use disorder, you might want them to go into alcohol detox and get some alcohol treatment before you start treating the other addiction. You know, particularly if the person is at risk for alcohol-related seizures. Again, this may or may not be obvious, but if the person is at risk for withdrawal seizures from alcohol, buprenorphine is going to treat the seizures. I don't know why anyone would think it would, but clearly somebody thought that, so they had to put it into the slides. It is important to realize that marijuana and cocaine are not absolute contraindications to buprenorphine treatment. So you can start somebody on buprenorphine even though they're using other drugs. I do it every week of my life. So I do it all the time. And it's important to work with them on their other problems, but it isn't something that should stop you from doing it, okay? So what else do I want to say? Stop here, there's 2 minutes left, and then we're gonna do our 2 questions. And then I think this is the one where we have a little bit of a longer break. So let me stop sharing. I'm gonna put up the poll questions for you guys, and then we'll take our next break. Whoa, that's not right. How do I get to Kay or Russell? I might need help. Like, where can I find the other questions? Because these are the old ones. Oh, wait a second. I'm so stupid. All right, launch polling. Sorry. Here's questions 3 and 4. I'll give you guys like 90 seconds to answer. Ooh, some of these we didn't get to yet. Darn it. So you have to have been reading ahead. Just having too much fun today. That's the problem. All right. Oh, there goes my alarm. these are not fair. I didn't teach you this stuff yet. Well, let's see how we do with the. Got 78% of the vote in. Almost there, guys. Give you guys a couple more seconds. Got 86% of the vote in. Oh, getting close. I stop it around 95. Give me a couple more handful of people to finish. All right. Okay, we've got 95% of the polls in. Share the results. Yes. Okay. Well, I guess what this tells me is I have to give you the information before I can quiz you on it. So the correct answers are B and A. So it's about 40% of people, adults with substance use disorders, have a co-occurring psychiatric disorder. I think you could make an argument about 60%. So that's interesting, because depending on what population you work with and where your office is, it might be as high as 60%. Question if you don't know that. Which of the following is contraindication to the use of buprenorphine? Well, I'm glad I scared you about the co-prescription of benzos. That's good, but that's not actually a contraindication. The contraindication is acute hepatitis. So if they're too sick from a liver standpoint, you probably shouldn't start or continue a person on buprenorphine. So, dude, terrible, Dr. Chris. I didn't teach you that stuff, but you will see it again. And the next time you see these questions, you will get them right. So it is 11:57. I owe you, I think, a 20-minute break. So we are going to start again at 12:17, if I did my math correctly. And at the beginning of the next session, I will answer the questions that I see on here. So, yes. Awesome, guys. See you in a bit. My goodness, where does the time go? 12:17 already. All right, let me get back to sharing my, well, let me answer a couple questions. 65 minutes from now. Oh boy, now the math gets worse. Kilter, so 12:17 to 1:17. 1:17 plus 5. 123. All right. About 120 something ish. Set an alarm. How do I do that? 1, 2, 3. Beautiful. Okay. Let's see. There was a question about oh, what should you avoid in asking about past traumas to avoid triggering anything? You're not always going to be able to avoid triggering anything. You might just preface it by saying, I'm going to be asking you some questions that might be difficult. If you don't want to answer them, just tell me you don't want to answer them. And then you can go into something like, you know, what I always ask about is, especially before the age of 18, were you exposed to any traumas like physical abuse, sexual abuse, or emotional abuse? And just leave it like that, and then just sort of see what they say. So it's not that you should really avoid asking about anything. And then I sometimes will ask, did you have any traumatic things happen to you as an adult? Because there are a lot of people out there with addiction that have childhood trauma. Then there's a lot of people that, because of their addiction, also have trauma, like they've gotten shot, or they've seen somebody shot and killed, or they've watched somebody overdose right in front of them, or you know, whatnot. So, or they've spent a lot of time in jail or prison, which can all be traumatic. So the way I generally do it is physical abuse, sexual abuse, emotional abuse prior to the age of 18, and then as an adult. And then that sort of helps me formulate what I'm going to do with that information. So I was asked about how long does it take to get into a practice like mine. Right now, I am scheduling into mid-September for a new patient, so it would take a little while. So that's the answer to that question. And let's see what else. What were the other questions? Sorry. so is it 40% or 60% for psych disorders? Well, there's the answer based on the slides, and then there's the real answer. So, you know, answer based on the slides is 40%. The real answer, we don't really know, right? And that's the annoying thing about test questions. Love it. All right, let's go back to sharing the screen. Where's my slides at? Okay, so we were talking about some of the initial stuff in the assessment. And again, if a person has multiple substance use disorders, you might want to think about getting them into residential treatment before coming into your practice. You know, it also says that remember that buprenorphine only treats opiate use disorder. It doesn't treat every disorder under the sun. It's not going to directly impact cocaine, cannabis, amphetamine, or alcohol use. You might have some indirect reductions. The misuse of other drugs can interfere with overall treatment adherence. And then you want to assess for the misuse and overuse of other prescription medications like gabapentin. I love to pick on that drug, my goodness. All right. Oh, why is it? Go forward. What is happening? No. Oh, something is really bizarre here. Huh. Frozen, and I don't mean the movie. Why? Let me stop sharing quick. Why did it do that? She asks out loud to herself. Okay. That's definitely working. Sorry. Try that again. Hope for the best. Yay. Okay. Whew. This is going to make me really nervous. Okay, so treatment agreements are important. You want to be very clear about what your expectations are and what you expect of the patient, and get the release of information from any other of their providers, particularly their last Suboxone provider, so you can sort of see what happened there. Again, you don't have to make this stuff up. It's all there for you. And then know the resources for addiction treatment in your community. If for whatever reason the patient is unable to hold up their end of the treatment agreement, there are a nice series of free documents called TIPS, which are treatment improvement protocols. They're all online, and TIP 40 and TIP 63 are the ones that are most closely related to buprenorphine treatment. So you can find sample treatment agreements in there. These are the things that are in a treatment agreement. Again, none of this is rocket science. Like, come to your appointment on time. Be courteous, you know, don't treat my staff like crap. Please don't be intoxicated. Don't sell, share, or give your medicine to other people. Don't steal, deal, or conduct other illegal things on my property. The medication will be provided during scheduled office visits. So if you're chronically not showing up to your appointments, don't expect to get your medication on time either. You have to have responsible and safe storage of your meds. Agree not to from other providers, physicians, pharmacies, or the internet without informing your treatment provider, and agree to follow the prescription instructions. So again, this is a review of your initial evaluation. Again, there isn't anything there that we have not already covered. And I'm going to get on to, first case study. Oh my goodness. So the case studies are going to be a little bit difficult, only because I don't have you guys in a big room where I can sort of divvy you up into small groups and stuff. So yeah, let's see. What I might do, because I can, is pick on somebody to read. Oh my God, now everybody's like, holy crap, she's gonna pick on me, she's gonna pick on me. Because I don't know anybody from anybody, right? And it's just like, all right, I'm picking on Matthew Hom. You lucky dog you, if you wouldn't mind reading The Lawyer That's Beginning to Use Daily. The good thing about reading is you don't have to answer the question. So unmute your mic and read, and I'll make your other buddies answer the question.
Okay, you just want me to read the whole thing?
Yes.
Okay. Mr. Smith is a 40-year-old man who comes to your office asking to be treated with buprenorphine. He is a criminal defense attorney in the private practice, and he knows about buprenorphine because you are treating some of his clients. His goal is to use buprenorphine during the week and occasionally use heroin by snorting on the weekend. He has used heroin for the past 5 years. For the past 6 months, he has used heroin primarily on the weekend, but he is concerned now because he has begun to use small amounts of heroin daily. If he doesn't use heroin, he gets loose stools, is irritable, and has difficulty getting and staying asleep. He has no desire to completely stop heroin use, but he doesn't want to use it during the week. His passion is playing jazz, and he has organized a band. He says that heroin use is common in the club where his band plays. All the members of the band use heroin, and many of his friends who come to the club also snort or inject heroin. He rarely buys heroin, as his friend usually give it to him.
Okay. All right, keep reading, and then because there's one more paragraph, and then I'm gonna move on to other people. So
his only other drug use is marijuana and alcohol, 3 to 6 drinks per night on the weekend. Again, primarily used on the weekend. He has never been arrested or had significant medical consequences from his heroin use. He is not married. He has a 14-year-old son who is supported and sees often.
thank you so much. I appreciate that. And now I'm going to pick people to answer questions. You're like, damn it, I should have volunteered to read. No, kidding. All right, I'm going to pick on Palvir Bad. I'm not sure. I apologize if I'm not saying that right. Can you tell us what the diagnosis is in this case?
So it sounds as an addiction of some sort. Definitely heroin. It seems like he's using it pretty frequently. He also has some other drugs involved, so marijuana, also alcohol. So
go back. I don't know if you can go back to the slide where you can see the criteria, but I'm just gonna pimp you a little bit. It's nothing personal, but is frequency and amount of use part of the criteria for a substance use disorder?
I would assume so, yes.
No, they're actually not. Right.
Okay.
So what you're looking for are, so if you wanted to at least get him to the moderate level, he would at least have to meet 4 criteria. I'm going to be very picky with you guys and have you go back to your 11 criteria slide, if somebody could maybe put it on the, oh, I should be able to tell you what criteria slide is. But anyway, the 11 criteria that I showed you, oh, it's slide 60. So the DSM-5 criteria. So in order to make the diagnosis of an opiate use disorder, you have to meet 4 out of those 11 criteria. And my question to you is, if you're saying this dude is OUD or opiate use disorder, 4 criteria.
We don't have the slides. Would you be able to pull up that slide for us?
You don't?
Chris, I have that if you want me to share it.
Can you? Do I have to stop sharing?
Yeah, or it'll stop sharing.
Okay, wait. I'll stop sharing. Okay, go ahead. Put it up. Slide 60. Oh, I didn't know you guys didn't have all the slides. Dang. I guess I just have the slides. There they are. Outstanding. So, yes. Yeah, inability to cut back. We know for sure, well, you tell me. For sure, I know he has 2 of them just from remembering the story.
So this patient, he was showing withdrawal from
that's one.
the diarrhea and
Yep.
stuff like that.
Yes.
And the fact that he's starting to use during the week would be social or interpersonal problems related to use.
Yes, it could also be tolerance. So you're kind of already at 3 with mild. So if you've got 1 more, you've got the diagnosis of moderate and you can proceed. But I just want you to be sticklers yourselves about, hey, just because someone uses heroin, don't just jump to, well, yeah, they must be a heroin addict. Well, no, go back to your criteria, just like you go back to the criteria for any disease. Go back to your criteria and say, what are the 4 criteria to put me in the moderate range? Because typically you probably could make a decision not to treat somebody that's in the mild range with Suboxone and maybe just save it for people with moderate to severe. But anyway, so can you pick out 1 more? Interesting.
Couldn't you just argue for larger amounts over a longer time?
You could argue larger amounts for longer time, right? Yes. So, and then we don't know about craving. So part of the answer also is, you know, the favorite answer of medical students. Well, I don't have enough information, so I'm going to need blah, blah, blah. So if you can show your attendings what information you would ask for, that's another way of getting around it, right? So, sorry, I'm not really meaning to pick on anybody. This is very, very light-hearted pimping. So, so it looks like we have a diagnosis of mild and possibly moderate, and if we ask him more questions, possibly severe. So now I'm going to pick a lucky winner. It's like the reverse lottery. It's like, shit, please don't call on me. Please don't call on me. All right, Selena Chandler, if you don't mind answering the second question, is this patient a candidate for treatment with buprenorphine? And I will add on I'll ask you to explain why. So don't just tell me yes or no, tell me why. And I'll even up the ante. Let's pretend it's your Suboxone clinic. Is this patient a candidate for treatment with buprenorphine in Dr. Selena Chandler's buprenorphine clinic? Because I got 149 doctors that might have different opinions on whether or not they would take on this lawyer.
In my opinion, I would say no, just because he wants to continue using the heroin on the weekends. His goals don't really align with the treatment goals for buprenorphine. So unless he was like willing to change his goals and like work on that for a little while before we start it, so I can really make sure like he's not just lying to get the medication, I would probably say no, he's not a good candidate
for your treatment in your clinic. Okay. Thank you. Very well done. So, okay. And then let me find somebody else to answer number 3 and then number 4. So, number 3. Let's do, I can't read it. Mark Kadzi. Did I say that right? What are the treatment goals for this particular gentleman, in your opinion?
Well, I think this patient's in the pre-contemplative stage of change. So we'd want to get him into the contemplative change or stage. And do like actual change. So if he's still planning on using heroin on the weekends, we'd kind of want to do some motivational interviewing.
Okay, that's a good start. Is there anything else you would get for him? So if you're telling him up front, like, dude, you can't be in my buprenorphine clinic with that kind of story, right? Or whatever, if that's what your goal is to keep using heroin, then is there anything else you would give him besides motivational interviewing?
Well, I know there's resources to help. So there's meetings that he can go to discuss his addiction.
Okay.
And I don't think pharmacologic therapy is the best option at this time.
There's one pharmacological therapy that you could give him that would prevent him from dying in the case of an overdose if one of his jazz buddies found him down in the bathroom. What is that?
That would be the naloxone.
Yes. So make sure he has a naloxone kit. I mean, at this point, that's about the only thing you can sort of offer him. You can also sort of give him information about naltrexone and methadone and the other possible treatment options. But I agree with you. I mean, the guy's just not like ready, right? And so now, again, they make this vague on purpose. And so if I did have you guys in a large room, there might be a person in the room that said, you know what, I would take this person on, and this is why I would take this person on. So, you know, perhaps. So if you're thinking about that and you think, well, shit, maybe I would take this guy on in my buprenorphine clinic, I would love to hear about it. But before that, I'm going to pick on one more person and then have them tell me the initial treatment plan. Teresa Russell. There might be a little bit of overlap, but is there anything else that you would do in your initial treatment plan for this gentleman?
So for him, like we mentioned before, I would make sure he goes home with a naloxone kit. For the treatment, I guess maybe I would probably try to set up a follow-up appointment, maybe. To check and see how he's going in the future. And then treatment, I guess, just try to get him some sort of support into some sort of group where he can just sort of be around people that are maybe trying to change, and just so he can start thinking about that.
What if he says, Dr. Russell, please just give me a chance. You know, I take back what I said. I'm going to really try to stop. Would you please just take me into your clinic? Would that convince you?
No.
Okay. What would you tell him if he said that?
Well, with that follow-up appointment, I would say, okay, you know, you want to do it? All right, I'll give you a chance. I don't know, a month later, come back, and maybe, I don't know, do like a urine test and kind of see, you know, where he's at. I don't know.
Okay. Yeah.
Pressure.
It's it gets a little complicated. And again, I think that the whole reason for this entire case is to get you to think about what, if your treatment goals align with the patient's treatment goals, then how do you negotiate that with somebody? So that's part of what is going on sort of very early on in the process. So thank you all for the answering, being voluntold to do something. I know that's like a major pain in the ass, but there's really not a lot of ways to do it else on Zoom. So I do appreciate that actually. So all right. So let me now see if I can get us back to where I was. Yay, here's the specialty topic. See, I was just a few slides short because I was having too much fun talking to you guys and answering your questions. Oh well. Gotta do something, right? So, okay, so co-occurring psychiatric disorders. So this is looking at the United States as a whole. So you've got 20 million people that have a substance use disorder. You have 43.6 million people that have a mental illness. And then you've got the middle of the Venn diagram, about 8 million people that have both. And then there's a proportion of people that are pure substance use with no mental illness, and then a proportion of people that have mental illness but no substance use disorder. So that's the basic sort of lay of the land. And you can see that this is 2017 data. And so one of the problems with epidemiology questions on a test is that the epidemiology is always changing. And so you can get tricked because you may know the most up-to-date epidemiology, but realize that the epidemiology questions that are on a test are usually 5 to 10 years behind and stuff. So unfortunately, you get penalized or penalized for actually knowing more than the test itself. So that sucks. Can't do anything about that. I'm just saying. So, so this is sort of my population, or my bread and butter is the person that has comorbid psychiatric disorder along with their addiction. And the most important thing to do is to try to figure out, which you can't always figure out, is this something that was caused by the drugs, or is it substance induced, or is it a primary and independent disorder, which really has nothing to do with the drug. So the note is that there's no specific period of time used to differentiate these disorders. The DSM-5 uses a cutoff of 30 days. So if you've gone 30 days without using drugs and you still have significant psychiatric symptoms, that's a very, very rough cut as their sort of specific period of time. But if you start to dig deeper into the DSM-5, how sort of loose that is. So a substance-induced disorder is when your psychiatric symptoms only occur when you're misusing drugs, and the symptoms are related to being intoxicated, being in withdrawal, or any other aspect of use. The onset or the offset of your symptoms is preceded by either increasing or decreasing your substance use. So the goal is to sustain abstinence and to reevaluate them. Easier said than done. So you're basically saying, okay, with brain diseases, go out there, stay sober for 30 days, and then let me reevaluate you in a month, right? So chances of that happening sometimes are not good. If the person has an independent disorder, then the symptoms are occurring even when they're not using or misusing substances, or if they're using the exact same thing every day, then their symptoms are still fluctuating. And this is sometimes when the family history can be important because, for example, if somebody has a very strong family history of bipolar disorder or schizophrenia, particularly in their first degree relatives, that might point you toward that they also have an independent disorder of bipolar disorder or schizophrenia. So again, the goal is very similar, try to get them to either quit using or stop using substantial amounts and then treat their psychiatric symptoms. The most common things that you guys are going to see are depression and anxiety in people with opiate use disorders, and most depression and anxiety is going to resolve within a few days of them getting stable. So it's not like they're going to have it all the time. I mean, again, by the time somebody gets to you and they're looking for a medical provider, they've tried lots of different things already, and including trying buprenorphine on the street, right? So, So, so symptoms that are persisting beyond the acute intoxication, which is something that you can start to treat. And what we do know is just because you're being treated with MAT, it's okay to give them psych meds on top of it because they respond to the psych meds at the same rates as those people that don't have opiate use disorder. So that's a plus. All right, so. Okay, so some of the things in terms of treatment is you want to avoid the risk of benzodiazepines. Again, because of the risk of misuse, your first line treatments for anxiety and depression are going to be your selective serotonin reuptake inhibitors, your SSRIs, so anything that's in like the Prozac family. Psychotherapy is also a consideration. If the person, sometimes you want to treat a person with a stimulant that has a psychiatric disorder. So for example, if they are claiming that they have ADHD, you're going to, again, carefully take a look at the ORS report, talk to their other psychiatrist or primary care provider. If there is concern for ADHD, try to do a self-report scale. I do keep copies of this scale in my office, the adult ADHD self-report scale. Or if you don't feel comfortable at all, just refer them to a mental health professional who can help you diagnose that. If you sort of do your whole, examination and you feel like they've got stimulants, they had them for 18 years old for ADHD, or they've had them since they're 10 years, and you can see that they've been legitimately prescribed by somebody for quite a long period of time, yeah, you could actually co-prescribe somebody with, like, give them Ritalin or Adderall and give them buprenorphine. Now, again, you're going to meet other people that work out in the field, and they might freak out with that, but I do it fairly often. So, but again, got to consider the source. I'm a substance, so there's a lot of people out there that'd be like, don't ever do that. So, but yeah, I'll do it if I get a good story. I'm not going to do it if the person comes in, I've never met them, and they're going like, dude, yeah, I need some of that that drug because I'm like unfocused, and I think it begins with an A. No, that's a person that's just gaming you, right? Like, oh, you mean Adderall? Yeah. Yeah, Adderall, but I need the blue ones, not the pink ones. Like a person that knows way too much about the pills, usually it's, yeah, that's a red flag. If the person, that's weird. I thought that now I have to find the answer to that question. I took the questions right off of here. That bums me out so much. Okay, the pregnant patient, if the person wants to stay on buprenorphine, then that's fine. Just that right now the gold standard is still methadone for pregnant patients. And so there's a lot of people that are on buprenorphine that don't want to switch to methadone. So you can keep them on the buprenorphine, just sort of make sure you get from them release of information from the OBGYN. And if you want to consider switching them to an equivalent dose of the mono product. So if they're on 16 milligrams of the combo, then you would switch 16 milligrams of the plain. So one of the reasons that you're allowed to use the plain formulation is when a woman is pregnant. Now, what always got to me was, well, if Dr. Chris, you told us that the naloxone was basically inactive if you're taking the medicine under the tongue at the way you're supposed to, then why in the world would you have to switch them to monobuprenorphine? Because technically speaking, neither the mom nor the baby should get any exposure to the naloxone. And yes, that's absolutely correct. So the reason that the OBGYN tell you is more of a theoretical risk that they might get a little tiny bit of the bioavailability of that naloxone, which could potentially cause something like premature labor. So I'm telling you that it's to the point clinically where a lot of docs feel comfortable with leaving the woman on the combo product if she doesn't want to switch to the mono product. And so, but the party line and the correct answer on the test is to switch them to monobuprenorphine. In clinical life, in the real world, a lot of women will just stay on the combo product. So I'm just, again, so, and the real gold standard answer on the test question is methadone. So if you do decide to switch them, you can just get them off of the buprenorphine and start them on the methadone. And then if you are going to give them methadone, they suggest that you do it in 2 doses a day, not 1 dose per day. And that has to do with the changes in the body's metabolism when pregnant. So so The FDA currently designates naloxone as pregnancy category B, and the formulation of the combo drug is category C. So basically, there's no known teratogenic effects in animals, but controlled studies have not been conducted in humans. So the recommendation, like this slide says, buprenorphine without naloxone is recommended for pregnant opioid-dependent women. But there is increasing evidence, and I think it's going to be very common very soon. There's increasing evidence on the combo formulation might be safe in pregnancy. So I think that's okay. But yes, if they ask what's the recommendation, it's without. Once they have given birth, you can transition them back to the combo formulation. However, if the mother is planning to breastfeed, then you should keep them on the mono formulation. So what I do when I get a pregnant lady is, again, 9 times out of 10, unless she's like really like doesn't want to switch, I'll switch her. And then for maybe the next 6 months postpartum, I will just keep her on the mono buprenorphine as she's trying to figure out if she's going to be able to successfully breastfeed or not. And then at about the 6-month point, I start to get a little nervous and I say, okay, we should probably switch back to the combo formulation at this point. So that's generally how I do it. But, you know, different people can do it different ways. If you decide to go the methadone route, formally, gold standard answer on the test question, methadone is still the first line treatment. You want to titrate the dose to effectively reduce cravings. You know that in the 2nd and 3rd trimester, you're going to have to probably increase the dose because of increased metabolism and increased circulating blood volume. And not only will you have to increase the dose, you'll probably have to split the dose into 2 times a day instead of once a day. That's why when you do that, you'll get less cravings and fewer withdrawal symptoms. So that's the methadone route. Now remember, there's very few methadone clinics in the country, have long waiting lists, and they're not generally located in rural areas. So if you can sort of justify all of that in your documentation, then they'll put them on plain buprenorphine. That's absolutely fine. So again, the methadone, if you're going to compare them as more structure, it's better for somebody that has a very unstable situation, like they're homeless, they're in a really bad living situation, because they're going to be very difficult for them to divert the drug if they have to go to the clinic 6 days a week. And we do have more long-term data because, again, methadone's been around since the early 70s, actually probably the early 60s, and buprenorphine for opiate addiction has only been around since 2002. So buprenorphine has similar efficacy, same rates of adverse events, but there's lower risk of overdose, fewer drug interactions. The babies that are born to moms with buprenorphine have fewer symptoms of neonatal abstinence syndrome, which is like the baby going into a little bit of withdrawal after they're born. They use less morphine and they have shorter hospital stays. I think there's some slides on this. Yes. So there was a very famous study, I think one of the most cleverly named studies in history of studies, called the MOTHER study. So that stood for Maternal Opioid Treatment Human Experimental Research Study. So the MOTHER study by Andre Jones and her colleagues basically found that babies born to moms on methadone on average needed a 10 milligram dose of morphine versus babies born to moms that were on buprenorphine that only needed a 1 milligram dose of morphine. And similarly, the mean hospital stay was lower for moms that were taking buprenorphine, like a 10-day stay versus like a 17-day stay for the baby that if the mom was taking methadone. And then the mean duration of being treated for neonatal abstinence syndrome was 10 days versus 4 days. So again, these are some of the slides that are pointing to the fact that pretty soon buprenorphine might be the gold standard over methadone in terms of treating pregnant women. So those were my few pregnancy slides. Now we're moving, this by the way is the special populations part of the lecture. So now we're moving into the treating the adolescent patient. So other very bizarre things about buprenorphine is that most drugs that are released for people 18 and older. For whatever reason, buprenorphine is approved for use in patients 16 and older. So there's that 2-year window of time with this drug that we don't get with other drugs. So the American Academy of Pediatrics says that yes, we need more resources to improve access to MAT for opiate-addicted adolescents and young adults. And they recommend that pediatricians consider offering this medicine to people with severe opiate use disorders. Because what you'll notice is that while bup is approved for people 16 and older, naltrexone and methadone, you have to be 18 and older. And if you're a minor, you have to have like your mom or dad's permission to get into a methadone clinic. So yeah, it's a big process. That's very, very, very rarely done. In fact, in 25 years, I don't think I've ever seen a teenager that young on methadone. I mean, I've seen 18 and 19-year-olds, not 16 and 17-year-olds. And again, you just want to, the induction protocols are very much the same. And so you want to encourage looking for adolescent-based programs in the community. The only program that I know of in Cuyahoga County is called New Directions. So that's the only place that does residential treatment for adolescents. And I don't think they have a very robust Suboxone program at this point. So still got a ways to go there. What about pain patients? So acute pain and chronic pain become very, very interesting issues in people that are on buprenorphine. So as you know, you're on buprenorphine, it's got very high affinity, very slow dissociation from the receptor. So what if the person gets into a car accident and, you know, crushes up their pelvis and they need acute pain management? What can you do? Because the buprenorphine is so strong that it's going to take a while to get it off the receptor. So what you can do is try non-opioid analgesics first. That's the first thing. You can continue whatever the buprenorphine dose is. Let's just say, for instance, it's 16. So continue 16 milligrams while they're in the hospital, but then add the non-opioid analgesics on top. You can take the buprenorphine dose of 16 and you can split it into like 4 different. Instead of taking 16 milligrams once a day, they can take 4 milligrams 4 times a day. So that sometimes works for people. And the reason that that works is that buprenorphine, as I told you in the very beginning, is a pain medicine, but its ability to control pain is only like 3 to 4 hours. And so if you split up the buprenorphine dose 4 times, you're going to get better pain relief with the buprenorphine than giving it all at once, which is the way you give it typically for addiction patients, is all at once. So then the other option that you have is to stop the buprenorphine and then put them on something like morphine or Dilaudid or Percocet to help them with, you know, their broken bone pain. So those are your choices, but it can get tricky. So okay, wait, oops, sorry. Oh man, sometimes it just, okay, yeah, sorry. All right, so what is having surgery? So it's not that they got in a car accident and broke their bones, it's that they know they're gonna have, you know, like a total knee next week. What do you do? So in terms of perioperative management, in general, there's a lot of mistrust on both sides. So the patients fear that the doctors aren't going to treat them correctly, and the providers fear that the opiate patient is going to lie to them. So there's that mutual mistrust that's going on. And there is currently a lack of consensus in the field. What they generally tell you to do is talk to your surgical and anesthesia team and figure out what you're going to do perioperatively. So what you can do as the Suboxone provider is make sure that you've reached out to the surgeon and or the anesthesiologist and get a signed release. And what generally happens is you can tell the patient to, okay, you're going to have your surgery on Friday, so take your last buprenorphine morning. So they take it that day, and then on Friday morning they don't take their Suboxone, and then they go into their knee surgery as usual, and then they give them in the hospital like the Percocet to handle the pain or the PCA pump or whatever. And then after they're done with that and they're going home, they can get restarted back on their buprenorphine. So it's fairly easy. That's one way that you can do it. It's not too bad. And, you know, and then you can transition them back. The other thing you can do is just leave them on the buprenorphine all throughout. You can you can increase their total dosage. So if you had your patient on 16, for the post-op period, you can raise them, you know, maybe for a week or two to 20 or 24 to get them through the worst of the pain. But then you have to have they say, a clear and detailed discussion with the patient about getting back to the baseline dosing. So, so yes, are you allowed to mix, you know, like with Percocet? So this is where, again, it gets really bizarre and complicated. So I'll tell you that in my clinical experience, I've noticed that it's about half and half. And what do I mean by half and half? So half the patients that stay on buprenorphine and take Percocet on top of buprenorphine, there's a percentage of patients that can feel the Percocet working on their pain above and beyond the buprenorphine. Not that the Percocet is getting them high, but the Percocet is relieving their pain, which is weird in and of itself, because you would think that they wouldn't even be able to feel it. And then there's other people that cannot feel it, and so they have to stop their buprenorphine, then take the Percocet for a few days, and then get back on their buprenorphine. So I actually literally explain that to surgeons, patients, family members, that I don't know by looking at you which one you're going to be. Some of you will be able to feel it and get some pain relief from taking medicine on top of the buprenorphine, and others of you will not. But you can at least start to have that discussion. So, but yeah, this is a very common occurrence. And at least in my practice, it's because my patients have, I told you, terrible teeth, and they're going to have oral surgery, and the dentist is going to pull out like 20 teeth at once. And they're like terrified. Like, what am I going to do? So I work through this with a ton of patients. What about if the person's on naltrexone? Now it's even more complicated because you're on a full opiate antagonist. So if the person is in pain, you can use your non-opioid options. If the person is having elective surgery, you have to plan ahead. If they're on the oral naltrexone, which, as you know, doesn't work as well, they would have to stop the oral naltrexone 72 hours before surgery. If they were on the Vivitrol shot, they would have to wait till the very end of their shot to have their surgery. So for example, if somebody had their shot today, they'd have to wait for 4 weeks when the naltrexone shot is basically worn off to have their elective surgery, okay? So basically don't take the next shot, have your surgery, and then after the surgery, get back on the shot. But if the person was in major pain or they were in an emergency situation, what you would have to do is do regional anesthesia, mixed plus or minus conscious sedation, and then plus or minus like general anesthesia. So a emergency situation, could one with mega doses of a high potency opioid override an opiate blockade caused by naltrexone? Yes, the answer is yes. So you'd have to have really, really, really high doses. So it's not something you would want to do at home. It's something that you're doing in an OR. So you can override the blockade. It's super difficult to override the blockade with street drugs, just doing it by yourself out in the neighborhood. But if you had to in an emergency situation, you could override the blockade, like in an OR setting. So just so you know, it's not an absolute thing. It would take a lot of medicine, but you could override it. So that was the acute pain. What about chronic pain? So chronic pain, again, a huge problem amongst a lot of people with opiate addiction. You want to consider consulting one of your friendly neighborhood pain medicine specialists. You probably want a multidisciplinary team, meaning the involvement of, physical therapy, occupational therapy, other types of therapies. You want to try as many things that are non-opioids as possible, and as many things that are not medications as possible. So whether that is massage, ultrasound, acupuncture, all kinds of different things that you can try, yoga techniques. So there are things you can do for your chronic pain patients. For your HIV positive patients, you know that the enzyme P450-3A4 is the primary hepatic enzyme that's involved both with methadone and buprenorphine. And many antiretroviral medications affect the bup or methadone levels, and in some cases the opposite is true. The buprenorphine or the methadone can affect the antiretroviral level. But what you need to know is that there are very, very, very few drug-drug interactions with buprenorphine, very, very few interactions with naltrexone, and methadone has the most interactions. So if at all possible, if you have it in your particular city, you can refer to a specialized HIV clinic program where they do both the HIV treatment and the addiction treatment in the same clinic. So at least in Cleveland, they do that at Metro Health. So at Metro, there's a couple of doctors that are infectious disease doctors, and they're also Suboxone prescribers. So they just sort of treat it all together. So what about failure? Yes, you can use buprenorphine in patients with renal failure. There's not a lot of differences in the kinetics in renal failure versus healthy controls. And both buprenorphine and methadone can be prescribed to people that are on hemodialysis. So that's usually not an issue. What if they have compromised hepatic function? Again, the potential is that you could have reduced breakdown of buprenorphine, with the result being higher blood levels of buprenorphine, that you adjust the dose down. There's no specific hepatotoxicity that methadone or buprenorphine causes. If your patient has impaired hepatic function, they should be monitored closely. And what they mean by impaired hepatic function is basically that if their liver enzymes are more than 3 times the upper limit of normal, then you should be closely monitoring them. So, oh, this is where I got it. Dang. I was like, where is that slide? Approximately 40% of adults with substance use disorder have a co-occurring psychiatric disorder. Methadone has historically been considered first-line treatment of OUD, but there's increasing evidence that buprenorphine is fine. And then buprenorphine is approved for people 16 years of age or older. Methadone and naltrexone are approved for 18 years of age or older. So those are the things that you should be thinking about adolescents. And then they summarize the stuff about perioperative pain. If you have an HIV patient, typically you would pick buprenorphine over methadone. It's okay to use it in people with renal failure. And, oh yeah, this was the answer to the second question. Unless the patient has acute hepatitis, pharmacotherapy is not contraindicated. So one of the very, very few contraindications is acute hepatitis. So, you know, if your liver enzymes are only like a tiny bit elevated, like 10 or 20 points off normal, go ahead. You can feel free to go ahead and do it. But again, if they're in sort of really bad acute hepatitis phase, they're probably hospitalized, not feeling very good. So you probably shouldn't start it at that point. So, all right, those are the references there. We're going to talk a little bit about how to get somebody started and some cases. But let me take a quick look at my question box. Oh, it says all slides are on A now. Okay. Does the red answer mean the right answer? Yes, the right answer is the right answer. Yeah, so that's correct. Yes. And oh, we're getting back. Somebody brought up the lawyer and said, "Oh crap! I gotta really open up this box in order to see it because it's driving me crazy." Sorry. Yes, 149 medical students, 100 different opinions. I would have said, give this lawyer patient the buprenorphine in order to decrease the likelihood of him dying from inappropriate heroin use. If he is given buprenorphine, he may be less likely to increase his abuse of heroin. Yes, true enough, but then you get into that funny little conundrum of you keep doing that knowing he's using heroin on the weekends. So it gets really interesting. All right, adolescent support groups, how are they different from adult support groups? Do you need parental permission to join a support group? The short answer to that question is, believe it or not, it varies state. So there are some states in the country where the adolescent must get the approval from their parents to enter addiction treatment. And then there are other states in the country where you can enter addiction treatment sort of without parental consent. And then there are also laws in particular states that are called the emancipated minor laws. So if you're 16 and you already have like a kid, you're basically like an emancipated minor, so you're allowed to make that decision. So it varies from state to state. I'm not sure that adolescent support groups differ that much from the adult support groups. It's just that the training of whoever the providers are is they're just people that have worked with, you know, adolescents. Some people actually, there's again a big debate in the world about maybe we shouldn't be putting adolescents in treatment because they just get put into treatment with kids that are more severe and they learn all the tricks and all the criminal activity from all those other young kids that are, you know, felons and deviants and whatnot, as they sometimes say with that argument. And so it can get tricky. So I think the decision to put an adolescent into treatment, you just have to maybe have a little bit more careful consideration. Like, am I doing this in more good kind of thing that you probably wouldn't take into consideration for an adult? So, okay, so we're still talking about the lawyer. The lawyer objectively should not be given buprenorphine. No, I'm not saying that. I mean, I think one could certainly make the argument, right? And I tend to be a softie, right? So one could certainly make the argument like, yes, I'm going to give you a chance. I hear what you're saying about what you want to do, and I'm going to use my first 2 or 3 months of having you in my buprenorphine treatment to use motivational interviewing on you and to get you to see that your way of thinking about trying to be a part-time heroin user just doesn't make a lot of sense. So one could imagine a very positive outcome with giving that lawyer medication and seeing if you can get that person over to your side. So that, I would say, is a possibility, but it's also possible that that person is just sort of using you. And so that's part of the rub. It's like, what you all have to answer, each of you for yourself, is what is my comfort level and what do I feel is the safest bet for this patient, and how much discomfort am I willing to tolerate on the patient's behalf to this medicine is worth a trial. Because personally, I think it's worth a trial on almost everybody, just to see if it'll help. Because some people just they just do so nicely on it, and you won't know until you start them on it. What is concerning to me about this guy is he's just so upfront about what he wants, right? So he wants to be a part-time heroin addict. And if that doesn't jive with your philosophy of treatment, which you can have a philosophy of treatment that says, I want to try to reduce as much harm as possible. So I want to try to reduce the harms of overdose, versus I really want people who want, recovery and eventually getting off of all these drugs and just getting out of the lifestyle. Those are the people that I want to help. So, and there isn't a right or wrong. That's a clinical judgment thing, right? So it is. And again, I think the case was written exactly for that purpose, is to get you to think about who's appropriate for my clinic with my license and my malpractice insurance versus another person's, right? Because as a medical student, you're all that stuff is covered, and you're not the buck doesn't stop with you. But one day you're going to be an attending, and the buck will stop with you. So you're going to have to make a decision about who am I willing to treat, and how far am I willing to go in terms of going to bat for somebody and giving them chances. Because I give people chances. If they mess up, I don't kick them out of my program. You're going to meet Suboxone prescribers that there's one mess up or two mess ups and they're just discharged. I don't care if you overdose tomorrow, you're just discharged because you broke the rules. So you have to say, what kind of doctor do I want to be? How do I want to write the rules? So the one nice thing about having the rules is if you break them, it's very easy. You're out. I think it's a little bit harder if you're willing to look at the gray and say, well, under these circumstances, what am I willing to do? So it's a daily, for me, it's a daily tightrope that I walk in terms of what am I willing to do and not do. So question about, can patients drive or operate heavy machinery while taking methadone or buprenorphine? The rough answer is yes. So there's very little, if you're taking it properly and you're at the right dose and you're past the induction phase, you should be fine. Where you're going to get the most danger is in the first 1 to 2 months where you're starting somebody. I would probably say in the first 1 to 2 months where your doctors are adjusting your doses, you probably shouldn't be operating heavy machinery. Yes, you can probably drive, right? Because again, you gotta ask yourself the question. Those are operating heavy machinery, and my contention is 60 to 70% of the entire construction workforce is heroin addicts anyway. So would you rather have them on methadone or buprenorphine, or rather have them high on heroin? So I know what my answer is. So yeah, they're already out there doing it. So again, I know I'm being very flippant and crass. I have a tendency to do that, but probably shouldn't because I'm being recorded and I'm going to get in trouble. But oh well. So yes, I would just say in the first 2 months, be super duper cautious. Once you've got somebody on a nice maintenance dose, you should be able to drive, just fine. Another interesting thing, if you want to get into really interesting political territory, is many states, almost every state, does not allow a physician that has an opiate use disorder to be treated with anything other than naltrexone. So they automatically, by law, disallow you to be on methadone or buprenorphine, even though in my opinion, there's no scientific basis for that. That's just pure stigma. So I think that's, again, I'll just bite my tongue, but that kind of stuff drives me nuts. So yeah, in many cases, especially in Ohio, doctors that have addiction problems have fewer rights than like felons, and it just drives me nuts because it's like, wait a second, we're human beings too, so give me a break. Anywho, that's another talk for another day. All right, so let's jump into the clinical uses of buprenorphine because I don't want to run out of time. All right, so there's three large sections of this talk: the induction phase, the stabilization, and the maintenance phase. And then if you happen to make the decision that you have to take somebody off of methadone, take somebody off of buprenorphine, I can tell you how to do it safely. But we'll spend the most time on the induction phase. So the induction phase is just getting somebody started on the medicine. The goal of the induction is to try to find the buprenorphine dose, the right dose at which the patient stops completely or markedly reduces their use of other opiates, that they have almost no withdrawal symptoms, no cravings, and very few side effects. So that's the magic. That's what you're trying to find. So it's going to be somewhere between 4 and 16. So you're just trying to find that little place, that magical place. So in order to start this talk, we got to talk about the different buprenorphine formulations. So we already talked about the fact that there's films, there's tablets, there's a subdermal implant. So we haven't talked about that yet. That's called probufine, P-R-O-B-U-P-H-I-N-E. Probufine is a subdermal implant that supposedly lasts 90 to 120 days, and it's given as 4 little rods in the upper arm. And then just about a year ago, subcutaneous injection in the stomach, not a deep IM injection in the butt, which is the Vivitrol or the naltrexone, but now buprenorphine in a formulation called Sublocade, S-U-B-L-O-C-A-D-E. It comes and in that formulation where you put it as a sub-Q injection into their stomach, and it lasts a month. So that's another option that we now have. So all of these forms are available, and there's even a transdermal patch of buprenorphine and a intravenous injection of buprenorphine, but those two are not approved for treating opiate use disorder. They're only approved for treating pain. So this is where we get into the discussion about the fact that if you're using buprenorphine to treat pain, you don't need to take the 8-hour class, and you don't need to have a special X license. If, however, you're using buprenorphine to treat addiction, then you have to have the special license and you have to take the 8-hour course. Again, I hope that all of you on the line can see how ridiculous that is. It's an exact molecule, but depending on what you're using it for, we've created laws. And the same is actually true of methadone. So any of you, as soon as you graduate, can prescribe methadone as you want to as many people as you want to treat chronic pain. Not that I would recommend that you necessarily do that because it's a very tricky drug, but what I'm saying is you all would be allowed to do that. The second you try to use methadone to treat a person with addiction, you have to go through a methadone clinic. So again, same exact molecule, different laws based on the person's diagnosis of addiction. So what if the person has pain and addiction? So now you get into that very interesting gray area of how do I write down that I'm only using this molecule to treat the pain, therefore I don't need an X number, therefore I can get around the 30 patient, 100 patient limit, versus, wink, wink, nod, nod. I'm kind of using this I'm saying I'm using it to treat pain, but I'm really using it to treat addiction. So then I don't have to have an X number. And you can see that you can get into all kinds of fun problems with that. So I generally tell people to be very clear about what they're doing, and the safest thing to do is to have the 8-hour class. So regardless of whether you're using buprenorphine to treat pain or you're using it to treat addiction, you're covered. So I'm very conservative when it comes to stuff like that because I like to not go to jail and I like to keep my job. So it's worked for me so far. So good formula. These are the various buprenorphine formulations. So these are the combination formulations. So you've got Suboxone, you've got generic tablets, you've got this thing called Zubsolv. Zubsolv is not generic yet, and they tried to differentiate themselves from Suboxone, having these really funky doses. So instead of having 2/0.5, they have 1.4/0.36. Ridiculous to me. It's a marketing thing. And then they have this thing that is a little sticker that you can stick in your cheek. That's called Bunavail or Bunavail. I don't know how to say it exactly. And again, they've got some little bit of fancy dosing. And then you've got the mono product, which is either a tablet or a implant, which is probufene, or the injection, which is called Sublocade. So right now I've only used the injection on one patient. So I have one Sublocade patient. I've never had a probufene patient. I've never had a patient with the implant. So, but mostly what I use is what's in this top box right here. And I use the 2s and the 8s. You can get the 4s and the 12s. They're just harder to get, and your pharmacy has to order them. There's even a 6 milligram available, if I'm not mistaken. But what I generally stick to is the 2s and the 8s. So, just so you know. All right, so how do you do a buprenorphine induction? First of all, it is so easy that you're going to end up taking this 8-hour class and go, OMG, I sat through an 8-hour class and it's that easy? Yeah, sorry. So that's part of the government mystique about buprenorphine. Like, oh my God, you got to take this 8-hour class, and then you learn about it and you're like, holy crap. So it's easier than you think, right? So the first thing to know about a buprenorphine induction is that as early as 2009, there were researchers that figured out that you could do a buprenorphine induction at home. So you don't have to do all this fancy stuff of bringing them into the office 3 days in a row. But when you see the slide deck always says, bring them into the office Monday, Tuesday, Wednesday, and get them, induced. But honestly, you can do a buprenorphine induction from home. There is one slide. I'm just telling you that in the real world, that's what you can do. So first of all, you have to have the fact that the patient meets induction criteria, right? Do they have a diagnosis of opiate use disorder? Can you look at your list and bona fide say they've got the diagnosis? Do they have the right insurance? Do they have access to a pharmacy that carries the drug that you want to give them? And do you have access to urine drug testing? If the answer to all those is yes, then that's one way to start. You could do the office induction where you give the patient the prescription, they go across the street, they get the prescription filled, they bring it back to your office, and then you do the induction in the office. Or you can do the home induction where you give them detailed instructions, you give them a follow-up appointment, and you give them their prescription. So for me, for the last, 5 years, I've been doing all at-home inductions. So I think what happened is that early on, 2002, 2003, 2004, the drug was so new that they actually had people going into the hospital for induction. And then they gradually started to do it as an outpatient induction. And then again, when something's been around for so long, they figure out like, oh, we can do it at home. So things have definitely gotten easier over the last 18 years. So part of why you see all this, like, this fear and all this detailed is like, because that's how it was at the very beginning. So here's the basic. And I'm not going to go through this slide by slide because I think the slides like way overdo it. But let me just tell you how to do it. A buprenorphine induction should take 2 to 3 days, right? So you bring the patient into your office, they bring the medicine with them, okay? You can start with 2 milligram pills. And what you do on day 1 is give them 2 milligrams, you wait 2 hours, they have to sit somewhere in your office, somewhere that's not a patient room and somewhere that's not a waiting room. So you have to have a different kind of hangout place for them. You put them in that different hangout place. You have like a nurse that's kind of like babysitting them to make sure that they're okay and that they don't like try to take anything out of your office and that kind of thing. You have to have them sit there, dose them at 9 in the morning with 2 milligrams. If they're still in withdrawal at 11 in the morning and still feeling uncomfortable, dose them at 11 and then dose them after lunch with another 2 milligrams and then finally dose them at like 3 o'clock with their last 2 milligrams. So office induction day 1, no more than 8 milligrams. The problem with that is no doctor's office has an extra hangout place for people to just hang out and do a buprenorphine induction. That's problem number 1, right? But that's what the books say you can do. Then what do? You give them a prescription for day 2, they go fill it, and then they bring in another bunch of 2 milligram pills to your office on day 2. At day 2, you take whatever dose you took on day 1. So let's presume they took all 8 milligrams, which is your max dose for day 1. They took all 8 milligrams. They come in on day 2. You have them take 8 milligrams all at the beginning of the day. And then you do the same thing. Every 2 hours, you dose them again with 2 milligrams until you get to your maximum on day 2, which is 16. So then by day 3, you can decide to bring them into the office. Don't really have to. So like literally, that's the office induction. Like it's that easy. And if you're doing it at home, you're just giving them the same instructions that I just told you, except they're doing it at home. The other issue is if you live in a state like Ohio, which has hundreds of thousands of opiate addicts, 95% of them have already tried buprenorphine on the street, or they've been treated with buprenorphine, so they know how to induce themselves, right? So the most important thing you have to remember with an induction is that the more you are at the beginning of the induction, the better your induction will go, the better you will feel when you start taking buprenorphine. Because if you are 100% comfortable, meaning you just took heroin like 2 hours ago, if you're 100% comfortable when you start the buprenorphine, you're going to feel like total you know what in about a half hour, because the buprenorphine is going to knock the heroin off those receptors and you're going to go into full-blown withdrawal. So the biggest mistake that people make when they're starting buprenorphine is they start it too soon. You have to be as dope sick as you can possibly stand to be before you start the medicine. Now remember, that is asking a person with heroin addiction to do a lot, which is to actually feel uncomfortable. Because believe me, people with heroin addiction don't ever want to feel uncomfortable. It's part of what keeps them sick. So they can't stand the uncomfortableness of the withdrawal. So they'll do anything within their power to always have some heroin nearby so that they don't ever have to go into withdrawal. Here comes you, the buprenorphine doctor, that says, hey, person with addiction, trust me, I'm a healthcare provider. And they're like, yeah, right. So trust me, I'm a healthcare provider. I'm telling you to get as dope sick as you can possibly be, like you feel like you're going to throw up all over the place. And that's when I want you to take your first dose of buprenorphine. And trust me, you'll feel a whole lot better than the buprenorphine when you're only having a very little bit of nausea. So if you start it too early, you're going to pay for it. If you start it as late as possible into being very, very dope sick, you're going to feel fantastic. So if you can use your powers of persuasion and the stuff that you learned in this class to convince your patient to do it that way, you're going to be very happy campers. And so are you. So that's really what I need to say about induction. I mean, like, yes, it is like, you know, it's like I tell people it's like falling off a bike, like literally it's like falling off a bike. So I think I may wait on the questions because we're up to time for our break again. So this is the point at which I'm going to remind you to please take a look in the chat box. We're in our last 65 minutes here together, and please, if you wouldn't mind filling out the survey at the end of this talk or toward the end of this talk, and the blue link is in your chat box. And then I've also shared with you, because I know there's lots and lots of questions, which I may not be able to get to all of them, just trying to get through all the slides with you all. So I've given you my email at UH as well as my personal cell phone. The only thing I would ask you is just please don't give my cell phone to patients. And if you need to give my cell phone to somebody else, just ask my permission so you can text me. So it's fairly simple. And also just to explain that this is the first 4 and 1/4 hours of the training. You have to finish 3 3/4 hours. And once we verify the attendance of all of you on this Zoom with the national office, then we get the link from them for the other 3 hours and 45 minutes. So I'm fingers crossed you'll get the link by maybe tomorrow after lunch is what I'm thinking. And so it was so long since I took it, but I think you need to get at least a 75 or 80% on the quiz in order to pass the online portion. And so once you pass the online portion, plus you do this live training, which will be done here in 65 minutes, plus you answer one more survey from them just to round everything out, and that will give you everything that you need at any point in the future. Suboxone to your first patient. And like I said, it's good for life, and you already know what an X number is. Just remember, take your DEA number off and replace it with an X. That's your DEA X number. So, so yeah. So let me get back to the slides. And where did they go? Here they are. Okay, so because we talked about induction, and I'm going to skip a lot of these slides. There's a couple things I want to point out to you. How do you know if somebody's in opiate withdrawal? So I call it dope sick, right? But you don't have to call it dope sick, but your patients will know what it is if you call it dope sick, because that's the universal term that they use. But if you want to call it opiate withdrawal, there's a scale called the COWS, and it's called the Clinical Opiate Withdrawal Scale, and it has these symptoms on it. So you're looking at usually an increased pulse, sweating, the person feels restless, their stomach is upset, they might be a little shaky, their pupils get very big, they have bone and joint aches, they are yawning, they have a runny nose, they have tears coming out of their eyes, they have anxiety or irritability, and of course they have the goose flesh. So the reason that they used to call quitting heroin or quitting anything cold turkey is that they would call it cold turkey is because you would get the hot and cold flashes and you would get the goose flesh. So that's why they used to call quitting like going cold turkey. So that actually comes from opiate withdrawal. And so there is an actual scale that is called the COWS that you can measure. Now, obviously you can't see the scale very well on here, but if you just Google COWS, Clinical Opiate Withdrawal Scale, there's a way you can score the person's level of withdrawal. So typically, if a person has a number of greater than 8, I think, at the bottom of this thing, which is very impossible to read, it says if you have a score of 5 to 12, that's mild withdrawal. If you have a score of 13 to 24, that's moderate withdrawal. If you have a score of 25 to 36, that's moderately severe withdrawal. And if you have more than 36, that is severe withdrawal. Let me tell you, most people start to feel really, really crappy at a COWS score of about 10. So they start to feel really bad. So, and most people with opiate addiction can't stand to have their score even be like a 7, and they're already like jonesing. So yeah, I've never seen a 36, that's ridiculous. So usually you're jumping in to treat them when their score is like about 8 to 10, just so you know. So basically what you're telling the person is, before you start taking this medicine, let's pretend you're doing a home induction. Before you start taking this medicine, don't use any opiates for 12 to 24 hours. So that's going to be the part where they're going to look at you like, is she serious? So don't use any heroin or fentanyl or any opiate for 12 to 24 hours. Try to be as uncomfortable and as dope sick as possible, and then start your first 2 milligrams of the medication. And then every couple of hours, if you're still feeling kind of crappy and your all symptoms have not gone away, take another 2 milligrams. Don't take any more than 8 milligrams on day 1. Don't take any more than 16 milligrams on day 2, and then I'll give you enough medicine for the week and I'll see you next week. That's literally how I do my home inductions. It takes me about a minute and a half to say that. And like I said, the vast majority of patients that I treat anyway, they're not buprenorphine naive. This is not their first rodeo. They've been around the block 5 times, so they know how to get themselves back on their buprenorphine. So just in the event that you meet somebody that's never been on buprenorphine at all in the last 18 years, highly unlikely, but just in case you meet that person, sort of the slides will tell you how to do it kind of by the book, but that's kind of how I do it. The other thing in terms of office education about buprenorphine, if you've never worked with a sublingual medication, you do have to hold it under your tongue for several minutes. If you happen to use the one that's like a little sticker that you stick on the side of your cheek, that will dissolve even faster. But again, the insurances don't like to cover it because it's not generic and it's expensive. But you want to instruct your patient to make sure they have a moist mouth, to avoid coffee or fruit juice, which they have a lot of problems doing that, because they like to smoke and drink their coffee while they're taking their buprenorphine. They're not supposed to do that. So no nicotine products, no acidic drinks. They should be quiet when they've got the medicine in their mouth. Keep dissolving the medicine under their tongue. After the medicine is completely dissolved, leave it in their mouth an additional 5 minutes before they swallow or spit out the remaining stuff. Isn't that so delightful? That's so disgusting. But anyway, those are the exact instructions for how do you do the sublingual medication. Like I said, most of your patients will be able to instruct you on which brands taste like total crap and which brands are better and which films melt the fastest in your mouth and blah, blah, blah. So they know all that stuff. But again, on the off chance that you meet somebody that's never been on buprenorphine in the last 18 years, absolutely they shouldn't swallow the medicine, less than 5% of it. They need to leave it under their tongue and let it get absorbed through the buccal mucosa. That's what it has to do. So they can't swallow the spit either, because if they swallow the spit, that's the same thing as oral absorption, as gastric absorption, which doesn't well. So it's got to get into their system through their mouth. That's why you're supposed to leave that stuff in your mouth for an additional 5 minutes. So those are the instructions. So I wanted to tell you that. So again, I'm going to skip through a lot of these slides. So yeah, so here's what you do. This is what you're telling them. If you're getting off of your opiates, stay off your opiates for 12 hours. I would never tell you guys in your first year of doing buprenorphine to try to switch somebody from methadone to buprenorphine. That's tough, because then that person has to stay off the methadone for like a day and a half, 2 days. And then things just get super complicated. So stay with heroin, fentanyl, Percocet, whatnot, okay? So just, it's 12 to 24 hours. And then let me, oh, okay. So let's, for instance, say you really botch the induction or the patient really botches the induction at home. All is not lost. They happen to take the buprenorphine too early and they start to get into precipitated withdrawal. Believe it or not, you have two ways of doing that. You can either try to hurry up and give them another dose of buprenorphine to try to override the precipitated withdrawal and suppress it. Or you can say, oh, we screwed it up. We screwed up the induction. We gave it to you too early. We're going to stop the buprenorphine right now. We're going to give you comfort meds. And so there's a generic list of comfort meds like trazodone and Motrin and something for stomach cramps and something for nausea and some clonidine. So they're all like non-addictive medicines that they can have for like a day or two. We're going to give you the comfort meds for your withdrawal symptoms, and then we're going to restart the induction the next day. So there's a couple of ways that you can do it if you manage to do, if you happen to do precipitated withdrawal. Again, the last 5 years that I've had home inductions, I don't think I've had a single case of precipitated withdrawal, mostly because my patients know what to do with buprenorphine, and I've given them such, instructions that, I've scared them so much that they're not going to try to take it early. So yeah, but just in case you do it, all is not lost. Like nothing bad is going to happen. So I want you to know that. So here's the home induction slide. Similar outcomes are noted for either an observed induction in your office or a home induction in terms of safety and efficacy. The most important process is that you have to teach the patient about how it works and how it's absorbed from the mouth mucosa. So you self-administer 2 milligrams of buprenorphine when you're having withdrawal. You self-assess again in 1 to 3 hours. If you're still withdrawing, give yourself another 2 milligrams, and you can keep repeating this until you get a dose of 8 to 12 milligrams during the first day. I always just say stop with 8. Like there's no need for them to go up to 12, but 8 milligrams in the first day is more than enough. And then on day 2, start with the dose that you started on day 1. So start with 8 right away in the morning, and then every 2 hours, and then to 12, and then to 14, and then to 16. So, and again, what if the person feels fantastic at like 10? Well, then they can stop at 10. That's fine, and then you just give them not too much medication to get in trouble with, but just enough so that, you're doing the math. So you give them like just the right amount. Now, a little trick of mine. So one of the things I hate to do is switch the person from 2 milligram pills to 8 milligram pills, right? So maybe I'm going to do the induction with the 2 milligram pills, but then on like day 4 or 5, then I would want to switch them to the 8 milligram pills. Yeah, right? So what you can do, which is even a quicker and dirtier induction, is forget the 2 milligram pills, give them the 8 milligram pills, and instead of telling them to take 2 milligrams 4 times a day, tell them to take 4 milligrams twice a day. Now, the only danger of that is you're giving them such a high dose to begin with of 4 milligrams that you have a slightly higher risk of putting them into precipitated withdrawal because that dose is so high. So that's why a lot of people like to start with the 2s. But sometimes I just get so tired of switching doses and all this stuff and having to call in another prescription and having to get another prior authorization, believe it or not, for a different dosage of pill. That just heck with it. I'm going to give you 8 milligrams. And on day 1, I'm going to tell you to take a half in the morning and a half like 4 hours later. And then on day 2, I'm going to tell you to take a whole one in the morning and then another half about 4 hours later. And then if you need it, another half 4 hours later. So for an induction, I can get you up to 16 milligrams by giving you 1 8 milligram pill for day 2 and 2 8 milligram pills for day 1 8 milligram pill for day 1 and 2 8 milligram pills for day 2. Guess what? There's your induction with 3 8 milligram pills. Or you can play around with 2 milligrams if you really like to do that fine tuning, right? So whatever you want to do, but it's pretty simple. Enough to take that milligram dose until the next time I see them. And I say a week, but it doesn't have to be a week. If you've got an office structure where you can start them on a Monday and then have them come back into your office on a Thursday, go for it. And then you can, that way you can control the amount of medicine that they have. Personally, like I said, you know, the office that I worked in, I was only there on Thursdays. So I would start your induction on a Thursday and I'd have you come back in a week and see me on a Thursday. So what would I give you for week 1? I would give you 13 pills. I'd give you 1 pill for Monday, and then I'd give you 2 pills for every other day. And then I'd say, come back and see me in a week and let me know how you did. I mean, literally, that's what I would do. So that's, again, quick and dirty. You won't see that on any slide. Some docs like to use 2s. I've learned to use the 8s and break them in half into 4s. You know, anyway. Okay, so then you continue to assess the patient when you're in stabilization and phase. And again, you can adjust your daily dose by increments of 2 to 4 milligrams as needed. Most people will feel super duper comfortable somewhere between 4 milligrams, 6 milligrams a day. My particular population, which has lots and lots of people with severe mental illness, I am one that typically goes over 16 just because I love insurance companies. And so I will sometimes push it to 20 or 24. I also treat lots and lots of patients with chronic pain, which is another reason to go up to 20 or 24. If you're just, you know, if you find the perfect opiate patient that has no mental illness, no chronic pain, nothing going on except for opiate addiction, they probably will do perfectly well on 8 milligrams a day, for real. So you don't, a little bit of this stuff goes a long way, right? If you have a person that has lots of severe mental illness, lots of post-traumatic stress disorder, lots of chronic pain, yeah, I'm telling you, from experience, you're probably going to need 16, 20, or 24 milligrams for that person. I'm saying, you know, that's clinical stuff. That's not something I have ever written up in a paper. So how long should you be on this stuff? So the evidence is variable, and we don't have a ton of evidence, although Dr. Dugan from NEOMED just did a beautiful lecture on it last Friday about some of the evidence that we do have. So we, at the time that these slides were written, there were studies that were only 16 weeks long that showed that if in a way that person was going to relapse. And so the short answer is you can continue buprenorphine maintenance as long as the patient is benefiting from treatment, meaning they're not using drugs or they've severely decreased their use of drugs. They're meeting their employment, their educational, and their relationship goals. You can see in red, right? Usually when they write something in red, that means pay attention. In red, patients about discontinuing the medication too early. So like I told you, sometimes I have to beg people, please, please, please stay on this treatment. It's helping you. I can tell that it's helping you. Because a lot of times people will be like, oh, it's been 6 months of morphine stuff, just take me off of it. What I tell people out the door is, look, I would recommend that you give morphine 1.5 to 2 years before you even start to think about reducing the dose. If at the end of 18 months or 2 years you just can't stand it anymore, I will off of it safely and easily. But please give it a chance, because sometimes you'll have patients that they feel fantastic after like 3 months, and they're like, okay, I'm off now, I'm good, I can beat this heroin thing. I've just been around long enough to know, no, you're not going to beat the heroin thing that easily, and you might need to be on this dose for maintenance. But a lot of times at the beginning, patients don't want to hear that. So yeah. So here again is a 12-month look at patients and it looks like they're looking at the percentage of days when the buprenorphine was taken. And so I'm not really sure about these curves. I was looking at this slide last night or night, and I was like, what does this actually mean? But I think what it is trying to say is that the more you take your medicine and the more regularly you take your medicine, your stability kind of increases. And what they found is up here, my interesting thing about the duration is if a person continuously took it, 90% of the time they took their dose, they had 14% fewer emergency room visits and 18% fewer hospital admissions. So if you take it, you have a really good chance of doing well. People that sort of take it and then they peter off, and they eventually will just sort of like stop taking it and not do as well. So just things to keep in mind. You've seen this slide already. So this is the difference between maintaining somebody on the medicine of buprenorphine and tapering them off of it. And again, this is a very short study, 14 weeks. So you know that by about the 3.5-month mark, if you start tapering your patients at the 3-week mark, you're just not going to do well. On average, they're just going to. You're better off maintaining them. Maintenance isn't perfect, but it sure will help a lot of your patients. What if you get into a situation where, for whatever reason, you just have to take them off of buprenorphine? Okay, well, the more gradually that you taper it, the easier it will be to come off of it, because you know that you're going to get the person physically dependent onto the buprenorphine, which means if you stop the buprenorphine cold turkey, they'll go into withdrawal within about a day and a half. So, well, this says withdrawal symptoms may not occur until 2 to 3 days after stopping buprenorphine. Okay, that's probably accurate. So for heroin, the withdrawal symptoms will start within 8 to 12 hours. With buprenorphine, the withdrawal symptoms will start between 1.5 to 3 days. So that's if you're stopping it cold turkey. But what I do with people is I might go down on their buprenorphine like 2 milligrams a month. So to get them down from 16 to 0 might take me like 8 or 9 months. So that's what I tell them. I'll take you off of it so slowly, you won't even realize that you're coming off the buprenorphine. Because what they are mostly is very afraid. So if I am going to take somebody off of it, I'll take them off of it super, super slowly. Now you can see that this slide says 30 days. I'm like, no, 6 months to 9 months. I'll take you off so super slowly. But if for whatever reason you have to take them off quickly, yes, you can take them off quickly, right? So this is just sort of this is a generic kind of thing, but you can take them off as slow or as fast as you want. Fastest I would probably take somebody off of 16 milligrams is like a week, but that's going to be painful. That's going to hurt. It'll be like 16 milligrams, 12 milligrams for 2 days, 8 milligrams for 2 days, 4 milligrams for 2 days, and then off. That's going to hurt. They're going to feel that, right? So it's not going to hurt as bad as heroin. They always think it's going to hurt worse than heroin withdrawal. And I always tell them, no, it won't. Believe me. So they never believe me, though. And then after you get to the very end of the buprenorphine taper, you can then give them comfort meds for like 3 to 5 days. And then at that point, it just feels like they have a bad cold, and it's not bad. Like I said, in 24 years, I've had 2 people that I've tapered off successfully. And the one that sticks out in my mind was a college student. She had to be like 22 or 23. And she, I had her on 16 milligrams. She's like, Doc, I'm done with this. I want you to take me off of it. So by the time I got her down from 16 to 12, she had relapsed on heroin. And the next week she emailed me and said, I think I need to go back up on my dose. So sometimes the patients figure it out on their own, like, yeah, this isn't going to work. So sometimes they just need to try it. And then they realize, no, I really need stuff. I crave too much, and I think about heroin too much when I'm not taking my Suboxone. So again, I'm going to not spend a whole lot of time on Vivitrol, just because this is not a Vivitrol talk. If you're going to pay for the Vivitrol shots, it's $1,100 a month. You do have to keep it refrigerated. You do have to be as sure as you possibly could be that that person has been opioid free for 7 to 10 days. And you can verify that by a point of care test. People will give what's called a naloxone challenge. So they will either inject the patient with a teeny tiny amount of naloxone, like 0.25 milligrams, to see if they go into withdrawal. And then if they go to withdrawal, obviously the patient wasn't telling the truth and they did use an opiate in the last 7 to 10 days, so you can't give them the shot. Or you can try a half of a pill of oral naltrexone, and if they don't go into withdrawal within like 4 or 5 minutes, then you're probably good to go in terms of giving them the shot. But you don't have to do either of those things. You can just straight give them the shot, as long as you're reasonably sure that they haven't used any opiates in 7 to 10 days. Okay, so side effects, we talked about that. We talked about the 7 to 10 days. I'm sure you'll see a question about the 7 to 10 days because it's only been mentioned 100 times in these slides. So, oh, one other thing. So you can actually also do heroin detox using buprenorphine, because just as in the same way you can do an induction, you can put somebody on buprenorphine for like a week's time and get them over the worst of the opiate withdrawal. But the problem with that is if you only give it to them for 7 days and you don't give them anything for after 7 days, you're just basically leaving them out in the cold and they're just going to relapse again. So again, brief withdrawal periods are unlikely to result in long-term abstinence unless you're going to plan on sticking them on a shot for at least 30 days. So you can certainly, and we do this at university hospitals all the time, we have a protocol where a person comes in with heroin detox and we can withdraw you from heroin safely using buprenorphine. The question always is, when I get to day 7 of my withdrawal, now what? What am I going to do to stay sober? So then you hit that fork in the road where I got to get them connected to a buprenorphine prescriber so that, they can continue the medicine. So, yeah. So if you're going to do the withdrawal using buprenorphine, that's what's on these slides. So you can do, like this says, you can do a 3-day taper, a 5 to 7 day taper at UH. So you're basically just in the first day getting them to 8 to 12, and then the second day keep them on 12, and then the third day. So it's fantastic, except after you're off of it, you're in the same boat at the beginning. So I don't recommend just using buprenorphine for withdrawal, because I'm kind of like, well, that doesn't make sense. What are you going to do for the active treatment? This is just the detox phase. So, so not a label there. Oh yeah, this is the, oh yes, this tells you, and again, I will not go, I'm going to go very quickly over this, but these are all of the comfort meds, which they call the adjunctive meds during withdrawal. So you can give them clonidine. So this tells you exactly how to do it. Clonidine is a blood pressure medicine. So the side effects are going to be sleepiness, dizziness, faint, headache, 0.1 milligrams every 6 hours. You just got to watch their blood pressure. And then there's, oh, they don't have it. No, they don't have the slide. So you can also give them trazodone, Tylenol, ibuprofen, Zofran for and loperamide for the diarrhea. So you just give them comfort meds for that. I wonder why they don't give out the other meds. Oh boy, sorry. My dog is barking, apologize. All right, good. The teacher. I call on right now. Oh, very beginning. Could I get Alexandra Tomasco to read Robert, the 35-year-old teacher? We'll do this case real quick.
The patient is a 35-year-old teacher. He has been injecting heroin on and off since he was 16. He has never been arrested. He has been through many episodes of heroin detoxification, mostly outpatient methadone detoxification, but has also been in 3 inpatient drug treatment programs. The last inpatient program was a 28-day drug-free recovery program, and he remained both heroin and alcohol-free for about 6 months following treatment. He teaches math at a junior high school and is in some difficulty because of calling in sick too much. His wife is in recovery and insisted that he return to treatment after she discovered that he was taking large quantities of codeine pills from several doctors for a back injury following an automobile accident. She is unaware that he is also injecting heroin at least daily. He has been alcohol abstinent for the past 2 years. His only current medication is that he is hepatitis C positive, and he has been so for at least 10 years. He states, "Doc, I know I'm an addict. My wife cleaned up, but when she was pregnant with our daughter, and she just got her 12-year chip. She moved on with her life, but I'm stuck. My back injury threw me into a tailspin. At first, I really needed codeine, but now I'm just using them to stave off heroin withdrawal. I need your help. If my wife finds out I'm back on the needle, she'll leave me this time."
Okay, so thank you very much. Appreciate that. Get to the next. Why is this phrasing ought to be? I don't know why it's phrasing. I could figure this out, seriously. All right, so let me go scroll through my little list here. Okay, I am calling on Benjamin. Number 1, does this patient meet DSM-5 criteria for opioid dependence? Remember slide 60, which I think you guys now have.
You kind of muted out when you were saying the name, Chris.
Oh, sorry, Benjamin Burdorf. Am I still?
Yeah, are you talking about opioid withdrawal?
Oh, opioid. Well, actually, this is a typo. It's opioid use disorder because opioid dependence is a DSM-4 term, not a DSM-5 term. So does this patient meet the 11 criteria that we have for opioid use disorder? And remember,
I think he meets 4 of them.
At least 4, right?
Yeah, exactly.
Yeah.
So I think he does.
Which 4 are you looking at? Because it might be different than 4 that your colleagues are looking at.
Let's go to, you said slide 60?
Yeah. Mm-hmm.
Give me a second.
Sure.
Chris, do you want me to pop?
Oh, he has cravings.
Yep.
Withdrawal.
Yep.
Inability to cut back with having used the opioids.
Yes.
Social and interpersonal problems.
Yes, he's starting to miss work. Beautiful. So he's got at least 4, so he's at least moderate. So Thank you very much. Now I'm going to call on, let me see. Rita Yakub. Second question, if you don't mind, what are the treatment options for this patient? You might need to unmute yourself.
Oh, sorry about that.
Okay.
What are the treatment options for this patient?
Second question.
I'm sorry, could I go back to the case one more time?
Oh, sure. Yep.
Okay, so for codeine, could buprenorphine work for that?
One, yes. Any other treatment options?
To stave him off of dependence, would you maybe something that would maintain, so could you, methadone?
Yes.
Methadone would work?
That would also work. Anything else?
It's on the tip of my tongue. Sorry.
The third one, right? The antagonist is the third option. Yes.
Oh, naltrexone?
You could. I wouldn't.
Okay.
I probably wouldn't in this guy because the chances of me getting him to be off of all opiates for 7 days without sort of locking him up on a unit somewhere are pretty slim because he's telling you he can't stop using. So, but
Okay.
yes. So the treatment options. There's actually the fourth treatment option is cold turkey. Don't use any medication. Again, would not recommend it. So you could use any one of the 3 medication options. You could do cold turkey and just put him into a treatment program. So those are your 4 treatment options. So
okay.
All right. Now let me talk to Neil Kapoor. How would you assess the need for pharmacotherapy for this patient? So this is a little bit more of a tougher question, like what types of things would push you toward or against methadone, naltrexone, or buprenorphine?
Okay. Well, first of all, he already tried the drug-free programs and they didn't work, so I think we're looking at medications.
Good.
And then between the 3, like you said, the naltrexone, it looks like he's not going to be able to be off it for 7 days. So because of that, we wouldn't go for that. And then between methadone and buprenorphine, like you said, methadone, it takes a longer, or it's less likely, I think you said, for them to be able to get into a methadone treatment center than buprenorphine. So I think buprenorphine for that reason, just for it's easier, it's more easily accessible. So I would go with that.
It is. Plus, if, it starts to get really weird, especially if you're trying to hide things from your significant other, that you're suddenly disappearing at 5 o'clock every morning to go somewhere, right? 6 days a week. They'll be like, what are you doing? So there's a lot of sneaking around going on. And then, so my question, going back here, let's go to Marissa Hollinshead. Hope I said that right. And this is, again, you, Dr. Hollinshead, with your ex-DEA license, is this patient Robert a candidate for buprenorphine in your clinic? I don't care about any other of your classmates' clinics. I'm talking about your clinic. Would you take this guy on? Why or
I
why
would
not?
I would definitely take this guy on.
Okay.
I feel like he's coming for help. I feel like he's really trying. I mean, he has a history of trying. He's in need, and I think with the buprenorphine, it could be a good option too, because he has a professional life, and just in terms of confidentiality and privacy for him, I think that could be a good option. So I'm a definite yes on this one.
So here's the bonus question. What do you do about him wanting you to lie to his wife? How do you work that when your patient puts you in the middle like that? I mean, there's no right or wrong answer. I'm just interested in your opinion on it. So.
Sure. So I think for me, personally, my place is with the patient. And so I think I would definitely maintain that privacy, but I would also, as a psychiatrist and a professional, just work with that patient to have a discussion around, openness and honesty with, I think that builds partnership. And there's obviously a lot of fear there. So I would want to try to work through that fear, but I also think it's really important to be able to build that trust with the patient and also feel that he does have a safe space and a place that he can go and try to get some help, because I feel like he's up against a wall right now. So I think that's where I'd start.
Yeah. So again, that's I think a thing that they should throw in there, again, just to point out that it does get complicated with family members and then them wanting you to hold secrets for them, and then do you or don't you, and that kind of thing. So, because remember, addiction is a disease of like deception and isolation. And so sometimes we can inadvertently collude with our patients with the deception and the isolation instead of, and sometimes we need to encourage them, like, not to threaten them, like, if you don't say something to your wife, I will. Not like that, because that's like totally unethical, but really just to use your, your strategies that you've learned about, what are the pros and the cons and stuff like that. So of doing it. Yeah.
Sorry, I keep stepping on you. Did you see the hepatitis C question? There was 2.
Wait a minute.
So no, not on that in the chat box. So there's a
there's
question
hepatitis C questions. Yes, let me look.
From Brandon. You see them?
Yeah.
Okay.
Yeah. Okay. Thank you. Yes, I saw a whole bunch of questions. Why do they yawn? I don't know why. It's such a great question. Yes, the yawning and the eyes tearing up. It's just part of the process. Would his hepatitis C diagnosis preclude consideration for methadone or bupe? No, it would just simply require the close monitoring. So yeah, you just need to get your baseline LFTs. Yes, you do baseline LFTs prior to prescribing. So the hepatitis C doesn't compromise the use of buprenorphine. What compromises the use of buprenorphine is acute hepatitis flare of any kind, A, B, or C. Because remember, hepatitis C is something that the person's usually had, and it's been kind of dormant for like 20 years. So many people that used needles like 15 years ago, they don't even know they have hep C. They come to treatment, find out that they have hep C, and then you hook them up with a liver doctor, and then you do a fibro scan and figure out how much fibrosis they have on their liver, and you do the liver enzymes to find out how much damage they've done to their liver. But I would say that 85% of my patients on buprenorphine have hep C. It's just not in an active hepatitis phase. So yeah, answer that question. So hopefully that that answers that question. So cool. All right. So thank you, Russell. You're not stepping on me. You are helping me out because I need help. I told you we talk a little bit about urine drug testing, and we will. So obviously this is something that I do routinely. Urine testing is a means for helping the doctor help the patient. Don't you love that? Help me help you. And typically the way I do it, I don't use the urine testing to catch the patient. And so just because somebody has a positive test result, I guess in some clinics and in the quote olden days, that would be like, oh, you tested positive, you're out of here. But now it's sort of a conversation and an opportunity to review the management of the patient. So here's some statistics. There's the roles of drug testing, which is you use it at initial assessment, during treatment planning. What you're trying to do is to find out what drugs or medicines they're taking that they're not supposed to be taking, and you're also using it to make sure that they're taking what you're giving them. So there's two reasons that you're doing the drug testing. And ideally, in the perfect world, drug test is random, observed, convenient, high quality, and gives you results on time. So let me just talk to you about that for a second. So in my world, I don't have a fancy enough office setup that I have a person that randomly calls people one day during the month and tells them you have 24 hours to get in here and give me a drug screen. What I do is every time they come in for an appointment to see me, they get their urine tested. So obviously that's not random. So if you're using cocaine, you can stop using cocaine if you can control it 3 days before you see me, and then the cocaine won't be in the urine. So what has been taught to me is that if you're doing non-random urine tests, that's an intelligence test. An intelligence test of, you know, how smart are you about stopping your meds on time, okay? So be that as it may, that's what I have. And the other thing that I say to comfort myself is, look, it's the disease of addiction. If they're getting out of control with their drugs, it will eventually show itself. Maybe I won't catch them this month, maybe I won't catch them next month, but eventually they'll get so out of control that the disease will make itself known. So don't worry about it. Plus, I strive to have such a good relationship with my patient that if I asked them the question, if I were to give you a drug test today, what would I find on it? They'll just tell me the truth. They'll say, I messed up. I've been smoking pot. I've been using cocaine. I've been having trouble with this and that. Oh my God, I like relapsed on fentanyl last week. They'll just tell me. That's kind of the relationship I try to have with my patients, right? So, okay, so what you do is you test for your panel of commonly used substances, and you perform the confirmatory testing. And what they're telling you is you don't need to do confirmatory testing at every single visit. I have to do confirmatory testing at every single one of my visits. That's just my way of doing it. But again, in terms of like the book, the book answers or whatever, you don't have to do that. These are the things that are most commonly screened for: your benzos, your cannabis, your amphetamines, your cocaine metabolite. So this is, you might see this word again. It's a fancy benzyl oil ecgonine. You wouldn't know it that it's a cocaine metabolite. So that's why they like to test you on it, that that's a cocaine metabolite. And then most of your opiate testing is going to detect morphine, codeine, and anything related to morphine and codeine. So for example, heroin is related to morphine, so that would come up positive. But if the person was taking fentanyl, that would come up negative. So way back at the beginning, somebody asked, does every drug screen test for every opiate? And so no, the generic ones only test for morphine, codeine, and codeine. So if you have drugs that are opiates that are in different classes, you might not catch them. And so if you want to get everything, you might have to specifically ask for alcohol metabolites like ETG or ETS. You have to ask specifically for buprenorphine and norepinephrine. You have to ask for fentanyl, oxycodone, or methadone if you want to find those specifically, okay? So when you test for buprenorphine, the reason you're buprenorphine is A, the buprenorphine I'm giving you, is it in your system? Are you actually taking it? Or if I've given you buprenorphine for the last 3 months and you've had 3 screens that have been negative for buprenorphine, then man, you're not taking it. So where is it going? Are you selling it? Are you giving it away? What I can tell you is you're not taking it. So, and then if you do the confirmatory testing, the real way to know if somebody's really taking their medicine is whether or not they're or buprenorphine in their urine. So I'm seeing like 8 things in the chat. So I'm like, something's very wrong. Okay, no, 10-minute warning. Okay, holy crap. Is it really a 10-minute? I thought it was like 1:38 when we came back. So don't I get until 2:38? Holy crap. All right. Boy, my math, way off. I thought 2:38 at least. Sheesh. Correct me if I'm wrong, Russell. Oh my goodness. So anyway, the norbuprenorphine is the most important thing. So what patients have figured out to do, right? So they're in the bathroom, they've got the pee. What they do is they hide a buprenorphine film or a buprenorphine pill in their pocket, and then they dip the film or dip the pill into the urine. They mix it around a little bit. So the urine test will come up positive for the buprenorphine, but it will come up negative or very, very little of the norbuprenorphine. So if you have a norbuprenorphine, the buprenorphine ratio that's very low, or conversely, if you have a buprenorphine, the norbuprenorphine that's very high, that suggests that the person was playing games and took the cup and swished around some buprenorphine in it to make you think that they were taking it. Very old trick. So obviously we at least know about that trick, which is why we always test for norbup in addition to bup. And we like to look for a high, buprenorphine, a high norbup to bup ratio. So that's what you're looking for. So, so anywho, all right. Let me move on here. All right, so, okay. Oh, this is like my favorite case. All right, well, let me, if we have time, I'm gonna go back. This one's fantastic. Let me spend a few minutes telling you, because, I'm telling you this knowing that you've got 1, 2, 3, 4, 5 to 6 years before you're actually gonna use this information. So I apologize, but that's part of what I have to cover. So when you get to that point in your life, because usually when I give this training, people are doing this within 2 days. So it's actually relevant. But if you're not going to do it for like 5 years, it's a little bit less relevant. But once you get to the website, which is the SAMHSA website, so you just find the SAMHSA buprenorphine waiver notification website, and I have to walk you through what you're supposed to do. So you will submit a 30-patient notification online. So the first question you'll get asked is, do you work for the US military, the VA, or Indian Health Services? You just answer that yes or no. You put down the state in which you are licensed. You write down your state medical license number, and you write down your DEA number. So you write all those 3 things down in the computer, you hit submit, and then it will say, oh, you happen to be eligible for a waiver level of 30 patients. And then your state, your medical license, and your DEA number will be pre-populated. And then what you do is just fill out the form. So the first thing you fill out is your name. The second thing you fill out is your medical license number, which will be pre-populated. Your state will be pre-populated. Your DEA will be pre-populated. government. They got to say everything 3 times. Then you have to give them your address. You can't use a P.O. box address. You have to, if you plan to store buprenorphine on site, you have to give them that address. Otherwise, you can provide your main work address in your licensing state. You have to enter your phone number, your fax number, and your email address twice. And then you have to check the box under number 6 that says, this is a new notification. Now, say you've done this for a year and you like it and you're like, I'm going to keep doing this. You would go back after a year and you would click the different box that says, here's the second notification of my 100 patients. But for right now, you hit the box that says new notification. And then you check the box number 7 that says that I certify that I will only use approved Schedule 3 Schedule 5 medicines to treat people with addiction. So they're just telling you to, just have to swear to that. And then number 8, here's where you have to remember back on July 16th, 2020, I did this training, because what you're going to have to figure out is that you put in here, you say you were in Rootstown and that you were in the state of Ohio when you did it. And then, so then then they'll be able to look you up in the computer and say, yep, that person did that training on that date. Box number 9 is you have to certify that you're going to refer patients for counseling if they need it. Box number 10 is that you have to certify you're not going to go over 30 patients in the first year. Box number 11 is the most important box. It's your consent to release your contact information. If you click consent, your name and your address and your phone number and your fax number will go to the National Suboxone Doctor Provider Directory. And so anybody in the country can find you. So a lot of docs might feel uncomfortable at first, and so they want to be like on the down low. So they just click do not consent. So only you will know that you have an X number, and you can treat as few or as many patients as you like. Once you click consent, you'll probably start getting lots of phone calls. So if you're trying to build up your business, you click consent. If you want to stay on the down low and you're a little nervous, you click do not consent. So in my opinion, number 11 is the most important thing. And then number 12 says that you haven't lied. And then you have to type in your name, and then you have to re-enter your DEA registration. And then you click submit. And until you see the green box that says your waiver notification has been successfully submitted, you haven't done it correctly. So they want you to make sure you see the green box, and then within 30 days, you should get an email saying, yes, you now have an X number and you can now treating patients with addiction. What if you want to start treating a patient with addiction right away? You go back to question number 6, and under question number 6, it says, new notification with the intent to immediately facilitate the treatment of one patient. So if you've got that one patient that you want, and you've got your DEA number and everything's all set up, and you don't want to wait 30 days to get that email, you can actually click that box. But most people don't do that. They just patiently wait for 30 days and all that good stuff. So, and then obviously there's lots of clinical tools. I will not belabor this point, but I mentioned it at the very beginning. If you go to www.pcssnow.org, you will have more resources at your disposal for treating opiate addiction with buprenorphine than you could ever dream possible. You could get a mentor, you could join a discussion forum, you can, other things. So yeah, these things are, those are the other slides. Those are the slides for the second half. So that's it for my part. If it is true that I actually am out of time, that's totally fine. If it's true that I'm out of time, then we can do my favorite case. But
it's true that you're out of time. So it is 2:30 is our contract for students. But there are going to be students who'd want to stay on. That'll leave up to you.
I'm not going to torture these poor people.
No, I'm saying they can get off. No harm, no foul. We won't even look at your names. If you want to get off, get off. If you're interested in the case, stay on.
That's just so crazy, though. But
you just want to cut it, Chris?
Yeah, let's just cut it. That's like torture. These poor medical students are trying to guilt them into this shit. No way, dude. They can't use this for 5 years. But guess what? It's done. And you know what? If you do get interested and meet people in the next 2 years, you'll at least know what is going on, and you'll at least know something about the buprenorphine, and you'll know, you know, who to connect them to, and you'll know how to find a Suboxone doctor because you can look on the doctor finder. So yes, there are ways you can still help your patients. So I really appreciate everybody's, cooperation. Oh, wait a second. Can I just give them the last 4 questions and then can we go? That way we can at least, I have to, guys, dude, let me just do this. 4 more questions, because I know you guys love to have these questions. Let me do a minute on these 2 questions and a minute on the other questions. So, everyone about to, oh, I want to do the questions. This is the best part. That way we'll have something to show the people at national office. I forgot. Give you the answers right away. Nice. Let's see what's going on. Give you 20 more seconds on this question, on these 2 questions. Okay, awesome. That's 90%. And we'll see, I'll share the results with you. You guys are so good. 66% of you got that question correct. The most important consideration during your induction is, has it been 12 to 24 hours since you last used the opiate, and are you dope sick enough to start the medication? So you got that correct. And the second question, the thing that suggests that buprenorphine was added to your sample is a very high buprenorphine to norbup ratio or a very low norbup to bup ratio. So love it. And then I'm going to give you the last set of questions, and then for real, we'll be done. So hopefully all that is being saved. Sorry. Stop sharing. Oh, go to the polls. Here we go. Last question. 3 and 4. Ah, yes. Launch polling. Here we go. It's like I wrote the questions. Might as well use them. Okay, 20 more seconds, almost done. Okay, we got 95% answered. Oh, you guys are too smart. Love it. Yes, you can continue buprenorphine as long as the patient is benefiting. We got 79% of you said that. Hooray, hooray. And yes, 59% of you correctly surmised that you have to have an independent DEA number to obtain an X waiver. Oh, let me just explain E. If you are a doctor on an inpatient unit, somebody comes into the hospital and says, I'm on 12 milligrams of buprenorphine from Dr. Delos Reyes up in Cleveland. You do not need an X waiver as long as they're on an inpatient unit. You can continue their regular dose. The time that you would need an X waiver is the time that they try to step outside the hospital. So once you move from inpatient to outpatient, you need that X waiver. So that's where things get tricky. But as long as the person's on an inpatient unit and you're just continuing somebody else's dose from whatever doctor that they're taking it in the community, you do not need an X waiver. So that gives me an opportunity for me to tell you that. So again, I went 5 minutes over. I appreciate you indulging me. We did get all 8 questions answered. And again, you guys have my email, and you can feel free to email me or text me if you have questions or get really interested in addiction medicine. Thank you, everybody. Take care.
Thank you, everybody.
Yeah.
Take care.
All right. See you later. Enjoy the rest of your boot camp. So.